do with this group of like-minded educators. So we're going to be talking a lot about how to teach on shift, how to teach in the chaos where we live and we work. And so the first thing to do before we kind of get into the guts of it and the kind of the how-tos and the why-tos is just step back for a second and ask ourselves why are we here, or why are we trying to learn more about how to do this well? Who benefits from that? Don't be afraid. You'll get it right. I promise you.
Learners.
The learners do. The learners do. Who else? What's that? Over here first? We benefit, right? Yeah. So many studies show that this really helps our professional performance. So it leads into our intrinsic motivation. It also leads to our extrinsic motivation to a certain point as well. Why is that? Emotion, right? How many of us are in the CE or clinician educator line, or at your place, the line that's closest to the person that does all the heavy lifting with patient care and the teaching? Does that sound kind of familiar, or where we're kind of heading maybe with our careers in the future? Well, it turns out the teaching evaluations really matter in your kind of emotional pathway. So that's extrinsic motivation. Who else? They love it, right? There are studies that show that they get much more out of their hospitalizations, that they learn more about their physical ailments, that they learn more about the system, they can navigate the system better after they hear juniors being taught by seniors. So why don't we do it more? Time. What else? Mental fatigue. I'm going to put some images up here and ask you what else comes up for you when you see these pictures? What else don't we?
Sometimes you're only working with somebody for like one shift.
Yeah, you don't know them, you don't know where they're at, you don't know how to target the teaching so that it lands. Do any of you have residents that look at you a little bit like this when you're about to embark on a teaching pearl and you're like, I don't know, I'm feeling a little uncomfortable, I'm feeling like maybe my script won't land, I'm feeling a little fearful. Did that ever occur to you when you were a trainee that your faculty might actually be a little bit afraid of you? Or is that just me? Am I just oversharing? Right? Damn, some of those residents are sharp as hell, right? And they're like, oh, I'm going to share something, I think it'll land, but they're going to be like, oh, God, really? No, I either don't buy it, or I'm going to challenge you, and I'm going to cite the most recent literature, and it's just like, okay, God, never mind, let's just go see that patient. Okay? Right? So what I'm going to encourage you to do is think a bit about what you can do at the very beginning of your shift, before you start trying to teach, before you start getting into teaching scripts and micro skills and spit and everything else that we're going to talk about, is setting up the environment so that both you and they can feed off of each other, be vulnerable with each other, and create a safe space. Now, the Dweck book, how many of you have read Growth Mindset or are familiar with Growth Mindset? Just Google it and do the Wikipedia, whatever it is that helps you get the kind of the teaching pearls out of it, because it will change the way you think. We have spent so much time in medicine creating exactly the system that we live in, right? So much fixed mindset exists in the way that we set up our teams, in the way that we set up our hierarchies, and we set it up so that we create this performance mindset that puts everybody into a state of fear. So when they're learning alongside you, they're not necessarily going to tell you what their teachable spot is, because they're afraid of looking weak. And what you can do at the beginning of your shift is have a conversation that enables them to tell you what it is that they need to know. You can highlight it and signpost it, that this is going to be a safe learning environment. I'm very low key. I want to know what you need to learn. Tell me how I can help you. I am not going to be grading you. I am not going to be high stakes. I'm not going to be that guy, right? So if you set that in advance, the whole climate will change, I guarantee you. And at the same time, give yourself the opportunity to show some vulnerability with them that you don't know, and you can't know all of the things, and you're going to learn together, right? So growth mindset for you, growth mindset for them. And that goes against the grain for many of us, right? But it can change the entire shift, and it'll really change everything about the way they learn with you. So, kind of talked about the safe space. What can you think of? What have you seen done in your clinical environments that help create the safe space? What are some examples? Things you can say, ways you can be.
Well, this kind of helps to like get to know my learner a little bit.
Yeah.
So I guess make sure I know their name, which can be surprisingly hard to remember somebody's name. Where they're from, things like that.
Just getting to know who they are. How many of you have been on a service when you were a trainee that you went to a new service and nobody ever figured out who you were or why you were there? Does that happen? Yeah, yeah. Or when you're working in the ED and you work with a resident for one shift and you cannot, for the life of you, remember what year they are. Are they an off-service resident, or is that great sub-I that I had on that other rotation I don't remember? And it's too late into the relationship, you can't ask. Do you know what I mean? You can't look at their name tag anymore because it'll be awkward. So,
Forgets that it's one of our residents he's working with. And now an off-service resident. You're really good at this. Yeah, it's because I'm the second year and they're just an resident.
it reminds me of when I worked with one of my new attendings at Kaiser when I was a resident, and I saw these shoes underneath the curtain next to me as I was doing an H&P with a patient. And I was like, well, I wonder who that is. And I kind of backed up and looked behind the curtain. There was this incredibly young-looking gentleman there. And I was like, hi. And he's like, hi. He's like, are you one of our new medical students? And I'm thinking I'm going to show him how to do a really good H&P. And he's like, no, I'm your new attending. And I was like, oh, God. Yeah, he ended up being my boss later, but that's kind of funny. All right, so you just have the conversation. All right, so other factors at play, right, we can go in with all the great intentions of having a great teaching shift, but this happens, and this happens, and this happens, right? And so what are the types of things we can do to just factor in the reality of teaching on shift? How can you design it so that it's more likely to be effective and even more likely to happen?
I think you have to make them realize that we're not going to have time for blackboard teaching at this point of their life. That's
Okay.
what I do personally.
Yeah.
You let them know that don't expect that. We're here on a clinical rotation, you'll be taught clinical forward.
Right on. So signposting the fact that these are going to be quick and dirty teaching interventions, right? And calling that out as teaching. Because we do that all the time. But they're so used to teaching, quote unquote, being up at the board, kind of like a little bit of what we're doing now, that they don't even register what it is that they're getting. Even saying it ahead of time helps them understand it. You can say something like, my teaching style is going to be quick and dirty in the moment, right? Does that work for you? And I thought, hell yeah. And then they're seeing everything you're doing is teaching, right? It's a little bit of a hypnosis, but it works. Okay. Yeah.
Obviously, it can also just be hey, we just had the same message. Let me say, at sign out, or at this time, we're going to do this. How like this.
Yeah. So setting up the expectation ahead of time so everybody can kind of make it more likely that they'll get there to that too and look forward to it. Exactly. Another way of doing it is, you know, the walk to the patient room. You're gonna, if you're a little bit worried about somebody, you're gonna be kind of wanting to go and check them out. Right. The walk to the room with the resident could be like a 30-second kind of prep, so you can make use of that time. And when you have an unstable patient, so there's ways of teaching for stable patients around spit and many of the other things that you'll learn a bit later. But there's ways of teaching around unstable patients, right? The ones where you have to get up out of your chair and go right to the bedside. What are things you can do in that kind of unstable moment that will help you teach, that will really stick to the learner? What are things you can say? What are things you can call out?
You can point out physical findings, but you can point out the fact what you're trying to do and why you're trying to do so we can understand the model.
Right, exactly. Did everybody hear that? You can call out what it is that you're seeing. In the chaos and the cognitive load of what's happening in the room for a new learner, they often have a really hard time separating the noise from the signal. Right, so you can articulate what it is that you're seeing on the monitor, what you're seeing on the quick bedside EKG, what you're seeing around all this information that the medics gave, right? So you can articulate that and kind of highlight that so that they know what to process. Right, so there's teaching in the unstable space, teaching in the stable space are very, very different. Another thing is finding teaching that finds its target. When you were a learner, did you ever have that attending that was so well-intentioned and would teach you all of these things that never were very exciting to you because they didn't really resonate with what you needed to learn? Did that ever happen to you, or is that just me as well? Yes. Ellie, tell me about it.
Yeah, the faculty was trying to teach me about a particular physiology that, number one, I didn't think was relevant to the kids, and I felt like they were just trying to prove that they know physiology about something. And here I am, I'm overwhelmed because there's 5 more pages for this thing, and they're just going,
Yeah, you're like, why? So you start getting curious about their intentions, right? You're like reading into all kinds of it's like, it's not landing with me. Why are you even telling me this? Do you not know that I have to go do this, right? So you're in your inner monologue in your mind and you can barely pay attention. And this is somebody who's trying to teach, right? How sad. How can we increase the likelihood that we can make if we make the effort to teach, that it's actually going to resonate with them and land the way we want it to have its desired impact? How do we do that? Ask them, who said that? Ask them,
what they know or what they understand about what they know. Figure out like where are they in this topic. And
ask
you
them
can
what they
figure
know.
out how to
Right,
break or do that.
yeah. So trying to tailor it, trying to assess, trying to diagnose them a little bit about where they're at in their learning curve. Right, so getting curious, asking some questions. How else can you figure it out?
You ask them their expectation, whether you're on a ship or a rotation, what's your expectation out of this ship or
Yeah,
rotation?
yeah,
And then you like basically you drive the car.
yeah,
And you teach them what you're expected to learn,
Yeah.
you're excited to learn.
yeah, exactly. Right, so you may have the ENT resident coming under your service, and you may assume that what they want to learn more about is ENT. And then when you actually talk to them, like, I'm going to get plenty of ENT in my life. I really suck at reading EKGs. Can you please review some EKGs with me? And then, like, everything lands like gold, and you can do that in your sleep. And you don't have to worry about, like, trying to impress the ENT resident with some, like, brand new way of tapping a nose that you don't know about, right? You can get totally into your comfort space, right? And impress the hell out of them, right? And feel really good in the process. All right, so there are a couple of other ways of figuring out where they are, but this is a really helpful framework that I have found over the years really helped me articulate things better. It comes from Schwank and Whitman, and it's around learner sophistication and trying to get a bearing on where they're at in their learning curve. And it goes from conscious and unconscious, and competent and incompetent. The idea, and I want you to imagine a face in each one of these. You don't have to share who it is, but I want you to imagine an actual person that you know who fits into each of these. So unconsciously competent is that faculty member who's such an expert that they can just walk into a room, they're like the Jedi, and they know exactly what's wrong with that patient, and they get from A to Z in like 10 seconds. And they go, we're going to do this and this and this and this and this, and they walk out and you're like, how did they figure that out, right? So much potential learning in breaking that down and articulating the thought process, right? Making the implicit explicit for your learners. And then there's a consciously competent, the resident, that cognitively goes through every step in the if this then, if this then, if this then. They know what they know and they know what they don't know, right? Really easy to target to. The consciously incompetent may be a great medical student who actually is honest enough to tell you what they don't know because you've created a space where they're not going to feel punished that they told you what they don't know. And then there's this guy, unconsciously incompetent. They look really confident. They look like they really know what they're doing. You assume that they do, and then you realize that they don't. Does anybody have a picture in their mind, that person? Okay, all right. How are you going to figure out that person? How are you going to figure out that person? What are you going to realize?
By asking questions.
By asking them questions,
Right,
and
because
yeah,
you can only teach someone if you know their knowledge base.
right,
The way to do that is how much do you know?
yeah,
You know their limit. That's when you're teaching someone
getting curious with them and kind of going down their pathway, their thought process a little bit more. And also by doing something like this. I want to just introduce this to you, and then we're going to get into kind of our debrief at the end. This is a fantastic faculty and learner development tool developed by the folks up at University of Washington called the ADAPT model. This is where you can have a little conversation at the beginning of your shift with a new learner or an old learner and say, what do you want me to watch you do today that you want feedback on, so we can debrief after the fact and have me spend about 3 minutes in the patient room with you while you're doing it. It can be having a bad conversation, a hard conversation, dealing with someone who's asking for Norcos. It can be having a conversation about a bad outcome on a CT scan. It can be anything, doing a quick stroke evaluation. You basically ask them what they want feedback on. You go in there and you watch it. You do a direct observation that takes maybe 3 minutes. You walk out, you give them their autonomy, and then you have a great discussion afterwards. This is a game changer because what they're doing is they're asking you for feedback on something, and they won't resist the feedback because they wanted it. So highly encourage you to try this on your next show. All right, so we're going to go through the first synthesis round. I want you to kind of meet somebody at your table and just share with each other what's one thing that you've learned from this conversation that we've been having so far, and what's something that's triggered something in you that you want to think about more as the day unfolds. We good? All right, we'll just spend about a minute doing that, and then we'll come back to session 2. just got the kind of nuts. Ready? Ding dong, ding dong. Okay, we are. Whistle! All right. So I hope you enjoyed that. I can hear lots of really interesting conversations happening at the table. So let's keep that up over the course of the day. Are we going to go ahead and switch into section 2? Sally, you can turn it on.
All right. So Susan and I are going to talk about elements, right? I mean, there should be a mic somewhere. I'm quiet. Yeah, thank you. I'm quiet. I'm quiet. I'm too quiet, and this morning people said I had to say, so I had to use a microphone. All right, so we're going to stand up. We're going to talk about clinical teaching. I'm not here by myself. Okay, so these are some ideas that you can use on shift, and so they're basically various teaching techniques that you can use clinically. All right, so the first one is what I call climbing Bloom's taxonomy. And so essentially what you're going to do is, if you've got a case of altered mental status, you're going to ask something at each level. And so a patient comes in with altered mental status, you might say something like, can you remember what happened? Can you remember something related to altered mental status? And then you might ask a question of, do you understand related to altered mental status? And then applying, analyzing, evaluating, creating. So basically you're going to ask a question that asks information or knowledge or synthesis at each of those levels. There is a AEM ENT paper on this. It's like a rip out that you can use. And it actually came from the surgical literature in terms of the surgeons in the OR are asking all of these remembering. Like, what is that? That's the common bile duct. And so we would encourage ourselves to be doing the higher level things. Ask people to synthesize and analyze and create. So we're going to give you each 3 minutes to practice. So grab your partner who's next to you that you were just with and go through altered mental status. So what kind of question might you ask to figure out what they know at a remembering level, an understanding level, analyze, create, etc. Okay?
another one. So the goal is to give you a few different things to kind of think of. Maybe you've used them, maybe you haven't. My name again is Promes, and I'm going to take the next one. So the next one is thinking out loud. One thing I think many of us don't realize as the teacher or the attending physician is sometimes you really need to be explicit about what you're thinking so that people can understand it. Like you and I can walk in a room and say, uh-oh, that one's sick, that person's going to get intubated, or whatever the situation may be. But somebody that's a junior learner doesn't know that until they've had that experience. And you need to help them understand how you got to that point. And I'll be honest, the more senior you get, it gets harder to do that because you're further away from how you used to think about things. So you have to really pause and reflect on that. So I'm going to give an example of this one. We're not going to practice, but give you probably two quick cases. One would be an asthmatic. Someone who comes in and they're breathing, kind of working hard to breathe, so everyone knows they're an asthmatic, but you don't hear any wheezes. You don't hear any wheezing. So a junior learner could walk in and say, asthma, oh, it's not bad. I don't hear any wheezing. And we all know that's not good, right? So that's one example. Another example might be somebody that doesn't have a lot of experience with taking care of children. And especially people in the room that are parents or have, younger nieces and nephews, a 3 or 4-year-old's usually running around the room. They don't like to sit still. So when you walk in a room and you're going to see a child that the parent's saying is really sick and they look fine, they're just sitting there, you have to be worried about them. Because some kids may be scared of sitting there, but others are sitting there because if they just try to move, their work of breathing can be difficult. So that's the idea of thinking out loud, describing that. If you walk in the room saying, I want you to come with me and pay attention to X, Y, and Z, because these are warning signs. You need to be very concerned. So that's the concept of thinking out loud, is to help your learners. And usually you do that with a more junior learner, or maybe somebody that's a more senior learner that hasn't seen a particular physical complaint, that we may know as more senior people. I think you can also do it for differential. You can, as you're discussing the patient, you may just kind of walk through what you're thinking, or ask the resident to walk through what you're thinking. All right, so that's thinking out loud as a technique. The next one is spit, and I think as Sarah mentioned that several times. So spit is that you're asking for a differential that includes something that is serious, probable, interesting, and treatable. And so that is because particularly early learners tend to kind of have a single diagnosis or tend to look at the wrong things, or they're just kind of all over the place and you're not pulling them down. So spit is particularly helpful for this. So serious, probable, interesting, and treatable. Again, that one I don't remember that was published because that was a bit ago. All right, so again, we're going to have you practice with your switch places and basically ask what's the differential for chest pain and spit. So that's your face. Sorry. All of a sudden I'm like, why aren't you doing it?
You ever thought of that?
So that one's pretty easy, right? Did anybody struggle with that? I think it's helpful, whoops, sorry. It's helpful that your learners actually expect that mnemonic so that they know what's coming, but you can say to them, please give me something that is serious, probable, interesting, and treatable. I almost wish that probable was last so that you ask them to commit. So maybe go through the 4 and then say, what do you think it really is, so that they can decide. So that is spit. Back to you. Stip it.
This next one is really a piece of the 1-minute preceptor model or the 5 micro skills. But one I think that's really important, so we wanted to spend a few minutes really talking about that. And that's the idea of getting your learner to make a commitment, to tell you what the diagnosis is. How many times have you worked with a medical student or one of your residents and they'll rattle off the differential? Or maybe they go on and on about their physical exam. And they'll say, I want to order this, I want to order that. Get them to commit. And that's difficult for people sometimes because they're like, well, it could be this, it could be that. So commitment is important because then you can have a discussion about why they chose that diagnosis. Especially when, ideally, you've seen the patient already or you've read their history, you know what the most likely diagnosis is, but again, get the commitment. I encourage you, if you're not familiar with the 1-minute preceptor model or the 5 micro skills, jot that down, go look that up, because I think it's a really helpful tool to use. It's been around for quite some time, but I think something you find valuable. There you go.
By the way, the handout that we're referring to is here, right? The little, I don't know where the little dinosaur came from, but so the handout's there. If you want to cue our dinosaur. All right, so teaching. Oh, okay, don't look at it yet. Don't look at the dinosaur. Okay, so teaching scripts. So we all probably have teaching scripts, but we haven't really identified them. But it's when somebody brings up a topic, and you can just launch into something that's a teaching piece. And you might teach for 1 minute or 2 minutes or 3 minutes, but you essentially in your mind have this kind of bulleted script of things that are important. And so, how do you approach patients with narcotics? What is your differential diagnosis with chest pain? What is oxygen? So we all have these teaching scripts, and it's important to continue to build those out so that you feel more and more comfortable talking about different things that you know. But basically, I identified that I feel comfortable or I thought through how I'm going to teach on 5, 10, 20, 30 different topics, and then how are you going to teach those things? What are the examples of teaching scripts for you all?
I like to talk about busyness and how you need to determine what's pre-syncope versus vertigo and how the differential varies.
We all laugh at your teams.
Yeah.
So really good. Your teaching share.
Yeah, share. Choose something that everybody else hates. And then you'll be like the star. It's like not another one about chest pain. I don't want that teaching script. Sorry. What else?
Because we see it a lot, and there's a lot of different ways to approach it.
I use supplemental status using the basic labs, and so each of them I would piece out like how would this help us with the supplemental status, so get them into really understanding, like instead of throwing in some labs, like it's a lot more for them.
Hope you did.
Yeah, 5 years ago. That's probably my top 2.
So those are just teaching scripts that you can all consider. So Ant-Man. Anybody know Ant-Man? Anybody know this person?
The population's way.
Yeah, I know, but that's the whole point. If I asked you, kind of like Jason did earlier on, to kind of describe an image of something, if you saw this individual and somebody introduced you and told you that was Ant-Man, you could pretty much recognize this person anywhere, right? Wearing a crazy hat with a little, price tag on it, looks kind of quirky. The concept is that there are certain things, that there are patterns that you should be able to pick up every single time. And so you teach to those. So, easy one would be a patient comes in with pain in certain dermatome, right? You don't see any rash. And you teach to, hey, when you have someone that comes in with these kinds of symptoms, and maybe they have one little pustule or papule, whatever, you've got to always remember that pain is going to precede the rash in somebody that comes in with something. What's another thing that you can think of that would be a good pattern that you teach people that they should remember? What can you think of? Tell me about that. How would you teach that? What would you say? might think of? Be a pattern that you could recognize?
Ascending coincidences, verbs, constructive habits.
That's really good. Yeah? Others? Ah, excellent, right? So once you've seen it, you know what that pattern is, that's something that people should absolutely pick up on. And you see how each of the different things that Sally and I have shared with you today are things that you could easily walk into a shift and use right now. They're not that hard, and they can add a twist to kind of what you're doing every day at the bedside. I'm wondering what other tips you guys use. Do you have other things that you use right now? We shared 6 with you, but there's many others. Other thoughts? Yes? It's kind of like the spit model, but just taking one piece of it. Yep. What else?
I think chest pain is quite essential. See several patients with pretty elevated blood pressure, and we've talked about how it's essential.
I also love the when Mary says we've been busy and everybody says, oh no, we've been busy. I learned this today. It's like, well, then all the patients we're going to see today will be abdominal pain plus we've been busy. So that everybody
That's not a safe learning environment.
All right, passing it on to you all.
All right.
All right, guys, can we have everybody stand up, stretch, you can sit long enough, stand up, stretch, and I want you to meet the person 2 away from you. You already know the person next to you. I want you to meet the person 2 away from you. To your left, Sam. Both ways. You found it. Yeah. All right, guys, we're going to go ahead and get started.
I'm going to try the Sarah Williams part once. Twice.
Once when you hear my voice. Once when you hear my voice. There we go. We got everybody back. Weak and dizzy.
All right, so everybody's primed, everybody got up, you've met another person. Again, my name is Alvarez, and now we're going to jump into applying some of the things that we've learned into a just-in-time teaching model. This slide is just to highlight that each of us have different trajectory in our workplace, right? There's going to be the rock stars who really love their job, and if you promote them, give them a new title, they're going to hate it. Because they figured out a way, all these teaching scripts, and they figured out a way of learning the system, so that if you give them a new title, then it's going to be overwhelming for them. They don't want to change yet. They just want to really, truly own that space. And then there's going to be the superstars that they want to get promoted, they want to get all to the next level, and if you just keep them at their role, it's going to be so boring for them, and most likely they're going to leave. And so the point here is that each of you, depending whether you're rock stars or superstars, can figure out, and by the way, it can change. You can be a rock star today and a superstar the next month. That's okay. But however you are and whoever you want to be, you can adapt the teaching styles that we're going to be sharing with you today so that you can be much more effective in your bedside.
We want you to be a better you, not a different you.
Yeah.
That's what we want. We want you to be a better you.
And there's going to be a lot of this back and forth later on because we're going to look at the slides like, why did we pick this slide again?
So Archimedes said, give me a place to stand. and I will move the earth. So he has a purpose, right? Has a place, has a mission. And you need to have that when you're teaching. We're not just teaching, there's a purpose to change their behavior, right? There's a purpose for them to teach another person, right? I want to make myself gone. I want to retire in a couple of years. So I want all you guys to come behind and take over. That's what I want to happen. So you can have this, where we're all working together as a team, or we're all just in the same room. And I don't know what my purpose is. So we're going to talk to you about just-in-time training in procedures. Now, we're going to tell you right up front that just-in-time training happens at the bedside. It is not the way to teach somebody a new procedure. You should teach somebody a new procedure by that mnemonic of learn, see, practice, right? So you're going to go through that. There's articles about it. It's in a handout about how to teach them to do a procedure. That's not what we're doing right now. We are, oh my God, I need to do an LP. I need a refresher. I'm a little bit nervous. I need your help. And how do we handle that?
LP.
Oh my gosh, we're going to do LP. I like that. So what issues? Sarah, we need you at the board.
Taught LPs already. Oh yeah, thank you, Dr. Williams. You're going to be writing stuff for us.
So, go on out here. What do you guys got? Positioning. Yeah.
I love that. What about positioning?
Absolutely. What else? Landmarks.
Oh yeah.
A little Anavan for everyone.
Yeah. I prefer to be
Including the person doing it. Okay?
Supplies in the kit, those not in the kit.
Ooh.
Right, what's in the kit, what's not in the kit? Oh, don't you love that when they're in the kit and they're gloved and they're like,
Yeah. Wait, where's the line again? Yeah.
What else? How to
Troubleshooting, walking it up.
Yeah, so if you hit bone.
And how do
Anything
you
else?
tell them that in front of the patient? Walking it.
Ordering the right LP
Oh, yeah, right.
Sure it actually gets to the lab.
Making sure it actually gets to the lab. I have done that.
Make sure it's labeled and it's tight.
Having some just like confidence, the patient has to read that they can do it.
That's right. How do they show up with confidence? Because they're freaking out. The patient's freaking out. Everybody needs out of that.
And
The right needle.
Picking the right needle. Wait, there's
wait,
options?
hang on. What? We got you. We got you. Quick needle.
We're modeling that we don't have to know everything.
Anything else?
Adequate anesthetic, yeah. Because if they're going to be miserable, then your resident's going to be miserable, then you're going to be miserable, then your investigating is going to be miserable, and everybody's going to be miserable.
So if we go back to what's been taught so far, this is a list of things that you guys run into pretty commonly, so it sticks out of your mind. Do you have a way to talk to the residents about each one of these before they go in the room? If not, you've got a teaching script that you can start. So step one is prep the learner, right? And it's really a step piece. We really need to say to the learner, how are we going to communicate? How are we going to do things? But the more important thing is that I want you to realize that you're going to be doing multiple steps when we do just in time.
The point of this slide is that, again, we want to emphasize that just-in-time teaching is not the place, so just-in-time teaching is not the place for you to teach ballet at a competition. It's just to actually have that conversation, some agreements ahead of time, and how you're going to be communicating during the actual procedure.
So clarifying roles.
Yeah.
So you guys mentioned it in the earlier talks about what do they know, right? So I want to know where you are in doing this procedure.
How do you ask that? How do you ask your resident, hey, have you done, like, oops. Yeah. Have you done that before?
How many have you done?
How many have you done? What do they normally tell you? A lot. Well, tons, right? Because why? If you say one or two, what happens? You're not doing that procedure because I'm worried about you.
So that's what we're really trying to decide, right, at the start. Who's doing the procedure? Am I doing it and modeling it for you, or are you doing it? I'm going to help you out.
Yeah.
And if you're doing it, how close am I? Am I right beside you, gloves up, mask up? Am I at the door of the room? Am I just stopping by going, how's it going, right? And that's not your decision as the learner, because everyone will be like, I'll be fine, right? So you've got to figure it out. How can you figure that out? Walk me through the procedure. Absolutely. Come on up and do the talk.
Yes.
Yes, walk me through the procedure. Absolutely. Another thing, what's in the kit, what's not in the kit, right? Tell me what you're going to gather to do this procedure. And if they can't gather the right stuff, they're not doing the procedure.
It doesn't get them to how many of this have you done? Because they have done 10, but if they can't walk you through the procedure, then at least you've learned from a learner perspective, like where they're at, right? You're trying to assess it in a way that also does not make them feel so threatened, like how many have you done? When they have to think it, like I've done 10 intubations when they really have not done anything, right?
And that's your role as an educator, right? Where do I need to be? What position do I need to be in? What is my purpose in this procedure? And I'm going to be here to support you and teach you, right? I'm not here to take it away. And you can say that because they're often worried that if you get your hands on that LP needle, you're going to finish it for them, right? And you may want your hands on that LP needle for one reason or another. But you're going to say, I'm not going to take the procedure away from you unless I absolutely need to. I still have the permission to do that. What I'm going to do is feel so I can know where you are. I'm going to do different things to know how I can best help teach you, right? But my whole goal is that you learn something during this procedure.
Dave, this sounds great, but I don't know how to do that. I mean, like, yes.
Yeah, so interactions in the room are crazy, right? Because once you're in the room, everybody's staring at you. Poker game, right? So those of you who play poker know you don't play the cards, you play the players at the table, and the players at the table are always different. So you're watching for all their cues and what they do to know how to play the cards they have. Everybody's watching. It's already scary enough. It's already scary enough, right?
And the patient is nervous.
So I'm going to do this procedure. I'm scared. You're going to watch me?
Yeah.
Oh, my God. I'm even more scared. Oh, my gosh, the family's going to be in the room knowing that you're watching me?
Yeah.
It's scary. So
I
you
call
gotta
it needle
calm down.
epilepsy.
Exactly right.
So how do we interact? Because I feel like we need to establish this.
Okay, let's talk about it.
Yeah. So we're going to kind of role play here a little bit. I am going to be the learner. David's going to be my instructor, faculty.
I think you want the next slide.
I think so too.
Great. So we're going to agree on a cue to stop, right? That's the biggest thing is I want you to stop what you're doing right now. I don't want you to do anything more. I don't want you to push that needle any farther. I don't want you to cut with that knife any farther. I don't want you to do anything right now, right? And we don't want it to be, stop! Did it happen? Right? What do you think happened in the entire place, right? Because that's what you want to do on the inside.
That patient is running outside right now.
Right? And the family's like, can somebody else do this procedure? We don't want that.
Yeah.
Right? We want a cue ahead of time. Cue could be it written on your glove. And then all I have to do is open my glove. Right? The cue may be, and my cue is, I call you by your first name because that's natural. So, LA, while we're in the room, if I want you to stop doing something, I'm merely going to call you LA.
Got it.
So you hear your name means stop.
That's great. And you establish this outside the room, so as soon as you walk in, I better not hear my name, because if you do, I better look at Dave. Right?
Stop what you're doing, look at me. Okay?
My patient is awake. I can imagine when I'm doing this, I'm going to struggle a little bit, because I haven't done a lot of LPs, and I'm going to ask you some questions. But I also need to look at my patients in front of them and kind of know what I'm doing. So how do I ask you questions?
How do you ask me questions? Well, we can do it in a couple places. There's times when you're going to ask me a question, like, is my needle going in the right direction? We all say that, right? Do I have the positioning right? So let's just make those cues,
Okay.
right? This is how I like to position them. Any changes you might make, right? You're welcome
You
to
see the
ask me
difference
that.
there? Instead of like, don't do that, or I don't think you should do it that way. This is one way of doing it. Is this what you normally do? So it gives me the language to ask the question in a safer way.
So if I hear that as a patient, I'm hearing that you know what you're doing, but you're asking if there might be a different way to do this. That's not a negative to me.
No.
That's a positive to me. Okay?
You can also anticipate certain parts of the procedure. I'm about to stick the needle. This
Right, I might angle that needle up a little bit more.
Got it. And so now I felt the pop.
Okay?
What do I do, Ken?
Is that your first
But I can
pop,
ask
your
that,
second
right?
pop, right?
Great. So walking you through what I'm feeling, I have to articulate. So we have this agreement ahead of time. This is what I'm going to do. And so if I fail, if I miss something, LA, and I'm going to look at you.
I can step in. But the key here, LA, is that I've got to stay calm. I've got to stay relaxed in my voice. Because I need to portray that this is a normal behavior between you and me, right? When we're doing anything. I don't need to cause you anxiety. I don't need to cause the patient anxiety. So I really need to maintain tone and cadence of my voice.
And you just heard that. It can be very nerve-wracking to teach an intern how to do an LP when they've not really done it. And there's a difference between, make sure you do this, versus, hey, Dave, this is the way that we're going to open this case. And then you walk in there, and then when you hear your name, just look at me. I got you.
Mm-hmm.
We're going to do this together. Training wheels.
Yes, absolutely. Training wheels.
We just did a just-in-time teaching about lumbar puncture, in this case, riding a bike. And it's the first time they're now going to be riding a bike without training wheels. So what are the pitfalls that you've encountered when you put yourself in this situation, teaching your learner?
Absolutely.
Oh, all right. You're constantly just getting like the reassurance. Am I doing it right? Okay. Okay. There's definitely that.
I don't like quiet learners.
Ooh.
I was doing an LP with somebody and they were just completely quiet.
Why is
I
that?
don't know
You don't
what's
know.
happening. Like, you have
Yeah.
to tell me what you're feeling.
Yes.
I don't know how.
Help me help you.
And LP is like a very tactile procedure.
That's
So like
right.
when you're the one teaching it, you don't know what they're feeling.
Yeah.
Then it's hard for you to like help them.
Yeah. Does that resonate? Oh, you should see everybody just like nodding their head.
Kind of like with introduction before video MHPE. You're like, what are you seeing? What are you seeing? And they're like, I just want to know what you're looking at so I know to tell you to go forward or come back. Just tell me what you're doing. So we can prep on the beforehand. Walk me through what you're doing.
And it's natural for people to forget, right? They're very nervous. For some of them, again, it's the first time the training wheels are just taking off. So just remind them. All right, so walk me through what you're doing. What else?
So I use the first name technique. I will occasionally forget it would be pretty fun. Is it when I call you doctor, or was it use your first name?
I use the doctor. I'm with you. I use it like if I call you Dr. Manthey, you pause and you look at me. But you
Whatever you decide to do, stay consistent.
Yeah.
Remind yourself. Maybe that's what I should write on my glove. Whatever you're doing.
Agreeing on shared terminology is hard. I'm like, oh, move the needle up, but is it up with respect to the patient? Is the arm
Ooh.
moving in three directions?
But this is key because we don't remember this. So sometimes I do the cephalad, coddle. All right.
I think one more aspect that needs to be brought up with the patient goals and learning specifically is the fact that after the patient, if they are still doing it, it's okay if you miss them the first time, but the peers are there to teach you where to go and how to do it and what not. But continue to ask patients how they're doing. How they're doing it, they continue with this procedure. It's important that special.
Yes, we're going to get to that in step 2. But absolutely, you're right.
Dr. Williams, we're going to ask you again to be our patient if that's okay.
Patient?
Patient.
Oh, we didn't talk about this.
Agreement.
Yeah, we did.
I don't remember it.
LA and I did. Yes, we did. We did talk about it. Okay, so actually, we talked about this before we go in the room, right? Because we're not to the patient yet. So
No,
before
not
we
yet.
go in the room, I'm the teacher in this scenario, and he's the learner in this scenario. And so I might say, LA, tell me 2 issues you've had with LPs before, and how are we going to address those?
Positioning, definitely. I think positioning is tough, and then, I don't know, I think sometimes like I'm just hitting bone.
So you hit bone.
Yeah,
Okay, so then we could talk about
it's
it.
gonna be okay.
Right? It's going to be just fine.
And again, we're doing this just like not with the patient in front of us because it's scary, right?
So my two would be that I teach all the time as a teacher is I'm worried about the positioning because if the positioning is wrong, you will not get the needle into the right place. And my second thing is knowing where the needle is going. How do you know that?
Yeah,
Right? 'Cause
up
you
or
have your
down,
fingers
or
on
which
the
one is
file.
up and which one is down.
Right, so one of the things is when I do positioning, I make sure that I roll, if we're doing it on the side, I roll to the bottom, to the patient's butt, and look up their spine to make sure that they are perpendicular to the ground. Because it's very hard to tell, is my hand perpendicular to you right now, or is it leaning back, or is it leaning forward? Can you tell? That's right, because you can't tell when you're looking straight at it. I specifically can't tell because I'm blind in one eye and I have no depth perception, right? So I have to roll to the back and look and see whether they're straight up and down. So I teach them that to make sure that they're straight. To make sure your needle's going in the right direction, I say slide your needle in until you feel the first pop because you're going through a fascia, right? It'll stay. That when it goes to that ligament, it'll stay. And then I want you to let it go. Because you can hold your needle however it's pointing, right? And you think it's pointing in the right direction, but when you let go, it goes wham. Well, that's where it's really going, right? So I have you let go of your needle so we can reset it right now. So we've just identified problems that he has, problems that I have, right, that I've encountered, and we've talked about them before we go in and what we'll do with them, right?
Yes.
So a little bit of prep.
I like that.
So what resources can you guys think of that you might use to teach before we're walking in the room? Because I'm not in cadaver lab. I'm not in SimStation, right? So what do you have available to you that you can teach with?
No, the kits, right? You just open it and you kit. That's very expensive. Okay.
So you keep a kit there. You know kits expire all the time. Just ask your nursing staff to keep the expired kits for you. Because expired kits can't be used on patients anymore, and they just send them, right? If they can't send them back to get them replaced, then they send them to trash. So just hang on to them, because then you can actually open it, and you're not opening a real kit. Cool, what else?
Video.
Videos.
Okay.
Videos, right? So do you have videos already planned?
Let's do
Yeah,
it
you go to
together.
YouTube, go to YouTube and go look for it. Yeah, absolutely. So you can do that off the fly, but if you do it often enough, you might find your favorite one, and then you can just bookmark it. You can bookmark it on the computer, you can bookmark it on your phone, right? If you have a website that's part of your residency, you can bookmark them there. All teaching stuff, so I get to them like that. Because one of the things why we don't teach is because, oh, it takes so much, and I think I feel stupid when I'm looking through trying to find a video, and then I found a video that wasn't the video I wanted, and it taught something that I didn't want, so then I was arguing with the video, and what the heck with it, I'm not doing it, right? So if I do a little free, just a little free, find the video I want, then I can have it. Great, video, what else?
Apps, okay.
Apps.
I like that. Who's mannequins in their department? Model. Intubation heads. Probably not for LP, but yes. Cervical LP. Cervical LP.
No.
We're adapting. We're adapting.
Any other thoughts?
What about just teaching them the approach, right? Because Ben just said, like, it's hard, like, we need to establish, like, up or down, like, what do you use? You use your finger? Okay. What else can you use?
I draw.
You draw.
I just lay out the spine process of how it's going to interfere.
So if I just had this, I could do it. Or a piece of paper.
I'm a terrible artist, but I get the point across.
Right,
Sure.
absolutely.
You can also make some low fidelity models sometimes with that. There's some really surgical towers for teaching sutures.
Yeah.
A tissue box for intubation.
Yeah.
So sometimes you get a little creative.
Absolutely.
I use the pillow for the pop. Because sometimes they just need to feel that, like, what is this, the pop again? Because in simulation, they don't really feel that, right? And so you want them to just feel. So tape, you can use tapes.
You have something here that you can use.
So you might be practicing, right, with the Gucci. And the reason for this is that, again, this, if you have this already out, so you can use it, but I wouldn't want you to, like, waste a brand new Gucci. But for those of you in the back, if I use, like, a real needle, you probably are not going to be able to see it. So we had to, like, think in this environment, like, what can we use so that the audience in the back can also understand what we're talking about? So blue, you can see pretty well, right? Pen is also a great idea. That's just pretty short.
Can I borrow it?
Yeah.
So if I'm trying to show you that I'm putting the needle through the back, right? through the skin, through the fascia, and I want to redirect that, right? If I redirect it by just moving the end without pulling it all the way back out to the skin, right? If I redirect it and it's gone through some type of ligament, one of two things are going to happen. That's the fulcrum, and all I'm doing is cutting, right?
Or bending the
Unless I'm
needle.
using that special needle you wanted to talk about. Right? I could do that. Or I think I'm bending it and I'm actually not.
Whoa.
Right? So I can get this information across by using something like this that explains to them, that's why I want you to let go of the needle, because the needle will show you where it's going. Right? If your needle does that, it's not going in the right direction. We're going to need to pull out and put it back in so it stays straight. Cool? So we can do it with different teaching aids.
What you've just heard, many ways of trying to do an LP, to teach something, and again, first day, like the wheels are off, it's overwhelming for the learner, right? And so whatever you decide, you have them commit, right? We learned about the word commitment earlier in the previous talk. Like, they have to commit to, this is what we're going to do. And so, Dr. Manthey, I'm going to commit to like doing this LP with his patients. We're going to do it like lateral decubitus, right? And then we have like different sets. We're opening the box. And then I go into the room and I was like, well, in this case, we're trying to model in front of me and there's no bed here and I can't do that. And so we have to commit ahead of time, stepping out of the room again. If I cannot do the lateral decubitus, I'm going to have the patient lean forward, and I'll do it that way. That way, we've anticipated things that we're going to be doing, so it's not stressful for me as a learner, and also they've already given me some guidance. It's stressful for the patient if you didn't know this. So by the way, this is actually very, very important. I think it gets to the next slide.
Yes, which is you walk in and see the patient, you got to prep the patient.
Yeah.
Now I've already prepped the patient, right? I've already prepped the patient that we're going to be doing an LP, why we're going to do the LP.
They signed the consent already.
But what we're prepping the patient for now is that there's going to be discussion. As he does the procedure, we're going to be talking back and forth.
Yeah.
We're going to be talking back and forth because even though we all do the procedure the same, you are different. So we may have to alter the procedure on your anatomy, right? And so there's going to be discussion. And this is not unusual. This happens with surgeons all the time. When the surgeons go into wherever and they run into something unexpected because of your anatomy or because of the issue that they're looking at, right? They don't go, well, we're going to wing it. They have a little discussion about what would be best. You just don't hear it as the patient because you're asleep. So you will hear us talking. That doesn't mean anything's going awry. It just means that the procedure needs to be modified for your body so that we can get what we need to do. So you'll hear us talking. Now that means I can't say stuff like, God, don't do that! Right? I have to be positive about everything.
Yeah.
Cool? So we have to prep the patient about there's going to be talk. There's going to be encouraging talk. We'll talk you through it. And I'll also talk to the patient about how much do you want to hear.
Yeah.
Right? I can walk you through and say, now I'm going to inject some numbing medication. Now we're starting with the needle. Now we're, and lots of patients want to hear that, and other people are like, just don't say anything.
Happy place.
Right? But we'll talk.
Great.
So now doing the procedure.
So we're going to ask the patient to lean forward, sideways. Thank you. Sure.
Here's your LP needle.
Perfect. I'm going to use the colorful one. So
Great. Great.
We're adapting. And so at this point, I've set up, and then we have that pre-agreement of what I'm going to be doing, right? And so I'm about to lean forward, and at this time, I'm just like pressing the back, learning the anatomy. And I'm going to say I'm about to insert the needle.
And so, notice what he's done? He stopped and he looked at me, right? So if he didn't look at me, the next words out of my mouth would have been, I like how you figured out where all the spinous process is. I like where you put your numbing medication. But in this patient, I might alter our approach so that your needle is angled a little bit more cephalad, angled up a little bit, right? Because I saw them doing something that I didn't want them doing, but I didn't know them, right? But he also checked in with me. This was a check on him. With me?
When you guys are talking and then you stop talking, that's kind of anxiety for both teachers.
Really?
That's very helpful feedback from this particular patient, right?
Really, we would know that.
It's like there's banter, and
Yeah.
then it got really quiet.
Yeah, so then if that's what you wanted, if that's what you wanted as a patient, I would continue talking.
Yeah.
And I've had patients say that, just to me the whole time. And I'm like, that's fine, I'll talk to you.
What you
the whole
just
time."
did there was pretty interesting though, because oftentimes there's this sense that we are walking on eggshells because we don't want to undermine the learner, taking the procedure from them. Like, how do we do this? Like, how did you said something that's like, LA, you might want to consider angling it down, right? Or I'm doing something and I feel like, can I model again? Perfect, thank you. I'm hitting bone.
Ah, so we've hit a problem.
Yeah. Think we're out of,
No, it's here.
Oh,
You
yeah.
got it. So I hit bone, right? We talked about this. You hit bone. But when he hits bone in real time, he's going to identify the issue for me. He's going to say, hey, I'm hitting bone. And I'll say, no worries. Happens all the time. What do you think the cause is?
I think I just hit the bone early.
Okay, so maybe the angle of the needle's
Yeah.
not right. Okay. What else might be a cause?
I mean, it could be, I guess the anatomy is off, like maybe I'm not centered enough.
Okay? And it could be that it's a calcified ligament. That often feels like bone.
Yeah. Not in our patient, of course.
Yeah. That would be a much older patient.
Anomalous, I'm anomalous, that's fine.
So you identify the issue, you identify the cause because we want to teach them, right? And then we identify how we're going to fix the problem.
Yeah.
So LA, when we go back in, let's change our angle. In
Right.
this patient, we can start down lower, closer to the vertebrae below, and angle up more.
So I'm trying to do that. I'm breaking the fourth wall here. I'm trying to do that. And I don't know, I'm a little bit nervous about what I'm feeling.
Okay? Then why don't you let me feel where we are?
Why didn't you breaking the wall again? He didn't ask me, hey, can I try that? Right? Or he's not tippy toeing. He's just like, let me try it. What is the difference here? Do you understand this idea that maybe sometimes we're so worried about asking people for permission to like do something that you know is the right thing to do, right? Like otherwise I'm just gonna keep on poking and it's not fair for the patient.
Do we have any residents in the room?
Yeah, we have several.
Residents in the room? Do you allow your attendings to push you out of the way to help with the procedure, or are you afraid you're going to lose the procedure? Yeah, it's a fear. It's a fear. So I've got to make sure that he knows the only thing I'm going to do, LA, is I'm going to feel whether or not I think that's bone or whether or not I think that's a calcified liver. That's all I'm going to do, and then I'm going to turn it back over to you. Cool?
And
So
one
you've got to
thing,
figure out what's the issue with the learner. Why are they behaving the way they're behaving? It's because they're protecting their space. They're protecting their learning space. And if you make it a safe environment to allow me to come in and just touch the needle for a little bit, now I'll take it over. I have to take it over, right? I'll take over the information I have to take over, and I'll explain to you why I'm taking over, right? It's my turn. I'll hit check it. That's all known in the start. But otherwise, I'll be like, let me just take a look at what you're looking at so I can help you, so I can troubleshoot with you. It's got to be a safe environment. You feel comfortable enough to let me step in and then step back out.
one challenge, if he asks me for permission, hey, can I try that? What if I say no? Then he now has to contradict me in front of the patient, which then undermines our relationship. There's a big difference, which is let me do this, right? Which we've established already outside. Hey, you're gonna get 2 tries or whatever else. If you hit a problem, I will. If I notice it, I'll guide you through it. But if I need to just feel it, right? Because it's tactile. As somebody mentioned, like it's a feeling thing. I'm gonna have to do that.
Okay, this is probably the most important step that you can do. And you mentioned it. You said you don't want them to become dependent upon us, right? You don't want them to become dependent on us. So one of the most important things you can do in a procedure is review what happened, right? And we forget that all the time, right? And residents don't want to review it, right? When we talk about that in patients, what?
Yeah. High five.
Yeah, but the janitor could have got it from across the room, right? That was not a hard indication. She did so many things wrong that we would want to fix an option. I'm not saying that to them. But if I don't spend that time with them to review it, then they think they did a good job because the outcome is good. Right? So from a learner standpoint.
Yeah. So what went well? Asking questions like, what was difficult about that particular case? Right? And perhaps maybe like, what is one thing I'm gonna read up on later on because of this thing that I just learned?
From the instructor standpoint, right? What could I have done better to make that
What's one thing that I could have done or not do to make this experience better for you?
Hey, LA, I also think that when we stopped talking, that our patient and the family actually became nervous. Did you notice that?
Yeah, I didn't until later when she said something that like she was actually nervous.
So maybe we should think about that next
Yeah.
time, right?
Yeah.
And LA, I'm personally, I'm going to go read on the different types of needles that are available to do LPs to make sure I know all of them, because really only two came to mind. I imagine there's more than that. So as an instructor, I'm going to go do some reading.
I thought I've done a lot of practice with this, but it's clear to me that there are certain populations that I may not understand, like the ossified structures that I need to read up more, just to anticipate that may come up.
Because if you don't do this, if you don't cement it in, then you just got through an LP. And you're going to make the same mistakes the next time, right? And so you don't want them to make the same mistakes, so you want to cement what they did well, cement what they did poorly, and how to fix it, right? And you want to give them a safe learning space. You also want to do that for yourself. And I'll tell you, one of the best ways for a learner to trust to talk to you is when you admit that you don't know something. So I truly believe the three most important words in the world are I love you, and the next three most important words are I don't know.
My favorite line.
To be able to say, I don't know, let's go look it up. Then they feel very comfortable with asking you. And you know what, that takes that stress off of me when they think that I need to know everything. Right? I used to know everything, but I got older and I forgot a lot of it, right? And so now I need to go back and look a lot of it up. Yeah, you're with me. Cool. So, at your tables, time-wise, how are we? LA, time-wise, how are we? Okay, so at your tables, if you will take a sec and ask yourself what you're going to do different in the future. Any one of these questions is fine. And talk among yourselves.
Pick a question. You can think more about this later on, but just pick one. We're hearing a lot of learning, which is great. We're going to share the love. So this table, what's a couple of things we learned? The cueing them, like knowing when to stop and start, like that. This table, any quick learning? What stood out for you? What went well? Again, we're just finding the right language to be able to interrupt and it still allow it to be safe space.
Yeah, but it makes it a team approach. It doesn't make it, I'm the learner and you're the instructor.
That's right.
It makes it, we're here together to make this the best procedure for the patient and for you to learn, not just get through it.
So we're going to land the plane now. We've learned a lot so far in this session, also in the previous sessions. We have to cement something that we've learned, which is exactly what we're going to do now, right? And we just did that, right? Each of you, as Dr. Wagner started earlier, we have different versions of the story, but now we're trying to consolidate that. Let's cement some key things. So what we did just now, I asked this table, that table, there's some consolidations of learning. Because what your learner may bring home is very different from what you wanted them to learn. And so this is also another opportunity to bring things together for them.
So how else do you cement learning with your learners? On a shift, how else do you cement learning? Any other thoughts? Recall, so what you learned during the shift? Yeah, absolutely. Anybody use Post-its? So every time I teach my residents something, and they go, that's a good point, I write it down on a Post-it, stick it to their computer. I have several residents who pull it off the computer and put it into a notebook that they take home with them. Right? That actually comes from Michelle. I don't know where she stole it from, but I'm going to give her that.
I'm getting goosebumps because in some ways you can also apply the Bloom taxonomy. Instead of just recall, you can try to apply what if, right? Can you create a model to teach this? But you see, there's different ways that you can teach this at the bedside, using just in time and after the procedure. Dave.
So the instructor,
Yeah.
just like we said, I have to look back over the shift and say, what could I have done better, right? Because oftentimes instructors come out of the shift and say, I did my teaching, I did what I was supposed to do, right? What we really should say is, how can I be a better teacher for you next time, right? And you can look at yourself and go, yeah, that was wrong. Or when I did that, I knew that I shouldn't have said that. I need to feel uncomfortable. I need to fix that in myself. I also need to look for what I'm going to go study on. But the other thing I'm going to do is what I'm going to do with you all right now. We've been teaching up here for 35, 40 minutes. What could we have done better?
Asking for feedback.
We're actually asking you for feedback. What could we have done better? It's tough. It's tough as the educator to put yourself out there and say, I know that I can do better. And I know that during this lecture you went, you shouldn't have said that, you shouldn't have said this, you took too long there, you belabored this point. But I'm never going to learn that. And I'm never going to fix that unless I honestly say to you, what could we have done better during this part of the week?
And it's also very intimidating to ask you in front of everybody, give us feedback, right? And also to ask you to give me a feedback of everything that we did. So maybe I can just ask the question, what is one thing that we could have done differently to make this a better experience for you? Right? Make the stakes lower. This is 7 seconds.
Yeah, it's good. Well, it's like 15, 30.
Sure.
I love silence.
Anybody? What's one thing that we could have done better?
Maybe have that board a little higher so we can see.
That's right.
It's kind of
Okay,
small.
great. What about the writing on it? Was it too small?
Hey, this is about you, not me.
Okay, higher board. Not figure it out. What else?
Similarly to that, this projector is kind of in the way of the different information.
Okay.
We had
Great.
Yeah.
So you're to the middle.
That's right. Yeah. Or we can also stand here. We've been standing in the front, right? We can make it more engaging actually. So you, the other hand. That's
We absolutely agree, and your point is absolutely taken in that it is time,
Yeah.
right? So we've done several things where we sent you to your tables to do it,
Right.
and then we have to pull you back, and I always feel horrible when I'm pulling you back, so help me with this. I always feel horrible when I start to pull you back and you're still talking, like we did it with you. You were still talking, you were making a point, everybody was looking at you, and you're like, talk to us over here, right? And I feel like I've stopped all of the learning that can happen. So how can I work on that? How can I make that better?
Well, I might leave because I'm thinking language that's not like you have to solve this for us.
Any thoughts? I have a clock. My clock was
Oh, yeah,
running.
he's been serving it. Oh, for the board, for everybody, to make it a group thing that like, this is the time. I love that.
Interestingly, because we have clocks, we have a timer on, we knew when it went off, and we have a program that tells us exactly where we are on the our time. So we are doing both of those things, but you're saying if we put a clock up for you all, so you have
Yeah.
5 minutes.
Include them. That's great.
I think we're going around saying what we're talking about as a group anyway, and if somebody is super engaging, like just having her finish her statement for the entire room.
Ooh, invite them. I can imagine the introverted me is going to be freaking out about that. What we just did there is again a synthesis round.
Just out of curiosity, do you find you get more insightful comments from learners when they are primed to the board feedback? So when you start a session, you find that we say, hey, we want your feedback from you at the beginning before anything happens, before anything else happens. Do you find you get better feedback from learners if you find that before anything?
Personally, I find that whenever you prime the learners, you get better feedback of any type, or if that's your behavior.
Yeah.
Everybody I know is when I start my shift, I'm like, how can I make you better? What can I do for you? What do you want me to watch? What do you want me to teach? What do you want me to pull up? How can I help you? And then they say, call all the consultants. Right? And I'll work with them, and I'll be like, why? And they'll say, because I want to see how you talk to consultants, because I'm having trouble. So I'm going to be right there beside you, and I'll be like, that's a great practice. I'll do that for you. But they also know at the end of my shift, my first question to them is, how could I get a better teacher for you on this shift? For you on this shift. Right? And some people will be like, well, I don't like when you do this. And the next person will be like, I love it when you do this.
Yeah.
Right? And that's okay. Because that's how I help them learn. And that's how I make it safe space. So sometimes just your behavior. We were talking about this over here, that with the safe space, when you mentioned safe space. I said safe space starts when you walk in the room. Right? I've seen some of my attendees come in 5 minutes early, and the tech brings them in the kitchen, and they're like, I'm not on shift yet. I'm like, you just told everybody in the room who you are. Right? I see other people come in and they hand them the kitchen, like, I got it, no worries, no, I got it, you guys take care, I'll get it to you later. Thanks for bringing it. Right? And they go, that person is safe space. Right? You develop a safe space with everything you say and everything you do and you perform.
And lowering the stakes for the feedback is also very important. If you have to wait until the very end of the shift, then it weighs a lot more. And so throughout the shift, I get asked like, hey, how did that go? What do you want to do differently? What's one thing that I could have done differently? What's one thing that I did not need to do to make your life better? Right? It's asking throughout the shift.
Back to your priming question, if there's a couple publications that support priming goes both ways. So priming the educator and priming the learner actually enhances. Because we can't pay attention to everything well. So if I know these are the three things you're focusing on, I'm primed out of it.
Whether you're a rock star or a superstar, I hope you learned a thing or two in bedside teaching, just-in-time training. Thank you so much. You were fantastic.
All right, so we've got a 15-minute break until 5 of 3. So break until 5 of 3.
Yeah.
That's good. That's just how I want it. Okay, none of this is logged out yet.
Okay, so you all are going whenever you can start whenever you want.
Okay, cool.
I'm gonna step out at 4 o'clock and I'll be back. Okay, sounds good. And you have until 4:30, 4:30, I think is the answer.
Do we have a little bit of extra time for the 10 minutes I had?
I think at 4:30 we're supposed to switch over, so you can go till, no, at 4:30 we'll go. That's okay. Yeah, because we're doing the panel meeting.
Okay, sounds good.
hoping to like stand and walk.
It's not working at all.
Did something get unplugged? Is that the one? Is it because this is
Oh,
up?
maybe. Let's try it.
There you go.
All right, everybody. So after that nice little break, we're going to go ahead and get started, and we're going to switch gears a little bit. So, as you could probably tell, the first half of the session was really centered on clinical teaching, bedside teaching, procedural teaching. Now we're going to switch gears a little bit and talk a little bit about didactic and lecture teaching. So we are going to talk about making didactic magic. And I have no conflicts of interest to disclose, but I do have one simple learning objective for all of you. So by the end of the session, I want all of you to be able to apply a simple 4-step framework for designing a didactic session. So let's talk a little bit about the lecture and how we actually define didactic versus a lecture. A didactic is broadly defined as a structured educational session that is given by a teacher to a learner or group of learners. And a lecture is essentially a form of didactic teaching. It's a didactic strategy that typically involves an oral presentation given by a teacher to a student. And for all intents and purposes, I'm going to use the two terms interchangeably. But to kind of delve into this a little bit more, it's helpful just to think about where the lecture came from. And the lecture is indeed old school, no pun intended. It actually started back in medieval times, where you would have these scholars who were teaching at these medieval universities, and they would actually stand at the podium and directly read off of the text. Does that sound kind of familiar? And this actually evolved into them developing lecture notes, but they would again just stand up and read verbatim from the podium. Now as time evolved, technology came into the mix, we got PowerPoint, we got visual aids, but also with time evolved our understanding of things like education and cognitive load theory and attention span. And people started to, rightfully so, question, is this really the best way to teach people? So, I think you can kind of see both sides of the argument to the question of, is the lecture dead? So for those of you who can think of some benefits of the lecture, what are some of the good things? Why do we still use this technique? What are some benefits to the lecture?
Provides educational knowledge to a large group of people.
Yes, it's scalable. It kind of still remains the most economic way to teach a large group of people. What else? And they like to stream it, right? Which brings me to another benefit, is it can be recorded and accessed asynchronously. So it can be flexible in that way. They can pause it, they can, use it to distill what's going to be on the test based on what it says in the slides. What else?
It can be an extremely efficient way to deliver a lot of information.
Yes, absolutely. You can cover a lot of content in a given period of time in a lecture. It takes time to, engage your audience and do activity.
It ensures a baseline level of understanding for another concept.
Absolutely.
But that's a challenge around flipped classroom and such sometimes is that they can even come into your school or into your classroom with such a variable set of past experiences that you can get jumped ahead too far if you don't have that baseline set.
Right, just kind of getting a large group of people on the same kind of baseline level of knowledge. Yes, speaking from experience, it is reusable. So it's something that you can archive, you can update it, and give it again. What else?
Caters to visual and auditory learning.
Yeah, so different learning styles can benefit from the use of various types of multimedia. What are some other maybe less obvious benefits of a lecture that you can think of? Have any of you been in a conference like this and gone up to somebody afterwards and said, hey, that was actually really interesting. Let's exchange contact information. I might like to collaborate with you. So it can actually be a vehicle to connect mentors to mentees. And it can also be helpful for showing data that maybe hasn't been published in a textbook yet, or allowing a lecturer to insert some expert opinion. So there are definite benefits to the lecture. Okay, let's think about the flip side. Why might people say the lecture is dead? Let's kill it. Put it in the grave. No more lectures. Yes. It requires some baseline level of presentation skills, which not everybody has.
Unless you specifically design it that way, there's not an engagement.
Exactly. It's super passive. It's often commonly thought of as like one-sided conversation between teacher and
I think more often than not, people put too much information into a lecture. Depending on what your intent is, what your audience is knowledge of it.
Absolutely. The scope doesn't always align with the amount of time given. And while it is efficient to give people a lot of information, sometimes that means they have to spend a lot of time outside of the classroom to actually then review the lecture, review their notes, and process it. So some people argue they're not actually learning during the lecture itself.
It's cookie cutter and doesn't adapt to the individual or some other factors.
Yeah, you're right. It's a little bit harder to adapt to your learner. Absolutely. And a lot of people argue too that it might not necessarily make your learner think. You're just kind of handing them information on a silver platter. So you can see this is a complicated debate. But the are listening to you, do things like think about different approaches to a problem solve, think about a case, discuss with one another, reflect on something. And these sorts of activities that you incorporate into lectures, they've been thought to actually strengthen neural connections and strengthen decision making that comes out of a lecture experience. And not only do they more closely mimic what we're doing when we learn in a professional setting, but they've actually been shown to improve learning outcomes. So is the lecture dead? As you can see, this is a complicated, controversial question. But I think rather than thinking of it this way, it's better to think about your idea of a lecture less so as a way of just kind of passively giving your learners information, and more so as an opportunity to synchronously co-construct knowledge with your learners. So through active learning, you could take something that might otherwise be a morbidly boring experience and resuscitate it. So I would say my answer to this question is that didactics that incorporate active learning are not dead, and that is a teaser to some sessions to come that will involve Ben is going to talk about using high-tech tools to incorporate active learning, as well as Steve is going to talk about what you might do when you don't want to use technology. So now that we've gotten that out of the way, let's talk a little bit about making didactic magic. So I really like this analogy when I was thinking of this talk, of thinking of designing a lecture kind of like designing a film. Except when you're making a lecture, you are fulfilling multiple roles, right? You're the producer, you're the director, you're the actor. But what I like about this is that just in the way that the brains behind the film come through in terms of showing the personality of the people who created it, you want your lecture to do the same for you. You want to insert some of your unique personality into your lecture. And part of that requires at the outset thinking, what am I bringing to the table? Why did I sign up for this, or why did I get asked to do this? Is it something about the way that I've chosen to break down this material to make it easier to understand? Is it something about the way that I've adapted the content to be specific to our given context? Ask yourself, what are you bringing to the table, and let your personality shine through. And if you're an education nerd like me, and you choose to do a whole fellowship on this topic, one of the first things that you learn about is Kern's 6-step guide to curriculum, which I wanted to just briefly introduce to all of you. Now, Kern's 6-step guide is really a framework for developing curricula. And when you think about the term curricula, it essentially means a planned educational experience. And any curricula comes with the goal of making a positive change in your learners. So this 6-step process, it's kind of a lot to take in. The first step usually involves identifying a problem that you're going to address with your educational intervention. And the way you do that is just by doing a general needs assessment, where you figure out what's the current approach to this issue and what is the ideal approach. And the difference between the two is how you identify your problem you're going to address with your content. Then you do a targeted needs assessment. That's where you actually talk to your learners and ask them what their needs are with regard to this topic. What do they want to know? What do they perceive their gaps to be? Then you move on to your goals and objectives. This is where you actually decide what you want them to walk away from your lecture with. And then your educational strategies. Are you going to use a lecture? Are you going to use a small group? Are you going to use a simulation? Then there's the implementation piece. That's when you actually take what you plan and make it happen. This is going to require resources and support. And lastly, evaluation and feedback. This is where you ask yourself, did I actually meet my goals and objectives? This is where you figure out what you can do better next time. I'm going to take this complicated education nerd stuff and I'm going to break it down and make it a lot simpler. I want to present you with this schema. It's a 4-question approach that you can apply the next time that you are tasked with making a lecture. Number 1, ask yourself, where are your learners? Where do you want them to be? How are you going to get them there? And how will you know if they got there? So number 1, where are your learners? The first step is really about performing a needs assessment. And I want to take a break here, and I want to ask all of you for a couple minutes to just talk amongst yourselves. Think about the last time that you had to create a lecture for something. How did you do this? How did you figure out what the current approach is, what the ideal approach is, and how did you figure out what would be highest field to cover? Or the next time you do this, how might you perform a needs assessment? So we'll do that for a couple minutes, and I'm just going to have you pick one person to report out at the end. So we'll give it to 3:12. And so I have this QR code at the bottom of the screen that links you to a double AMC resource that's super high yield, super concise about how to write robust learning objectives, because there definitely is a right way to do it. A common pitfall is that people see this term and they think that they basically need to just list out their agenda for the talk, and that is not actually a learning objective. A learning objective is outcomes based, and it should start with the sentence. After participating in the session, attendees should be able to ... And then it should start with an action verb. And even just the verb itself should be written with intention. I think we've seen this pyramid come up several times now, Bloom's taxonomy. We love our pyramids in education. And the verb should correspond to the level of Bloom's taxonomy that you want your learners to achieve. And this can be tailored depending on your learner group. For instance, let's say you're doing a lecture on chest pain, and you're teaching clerkship students about how to basically approach chest pain in the ED. You might pick a lower order thinking skill, like remember, on the bottom of the pyramid. And you might use a verb like recall. Recall the most common risk factors for ACS. Or let's say you're teaching like senior EM residents who have an interest in operations about chest pain. You may want them to walk away being able to create an institutional protocol about how to discharge low-risk chest pain. So you can see how you can vary that verb that you use based on what you're trying to achieve in terms of the level of thinking skills. And not only do you have to be intentional about your verb, but you also want to write your learning objective in a way that is specific, measurable, and observable. So who can tell me the difference between this red text, explain leadership in the resuscitation bay, and explain 3 essential elements of leadership in the resuscitation bay? What's different? Yes, it's much more specific, it's much more actionable. So there is an art to writing learning objectives, and I want you to think about this the next time that you have to do it, and you utilize that resource. The next thing that is really challenging is figuring out what to cover within the amount of time that you have. And this is so tough, aligning scope with the duration of the lecture. And the people that I have seen who are just like the master educators, they all share in common that they are able to just ruthlessly cut content from their lectures. So how do you do that? Well, I would advocate for starting broad and funneling down. And when you get to that funnel, that's where you pick your learning objectives. And I would argue to pick no more than 3 max, 1 to 3. And so how can you do that? You can use a couple tools. I really like this concept of a spray map. It's kind of like a mind map or a concept map, but there's not really many rules to it. You just write your topic in the middle, and then you branch out all the possible things you could cover in the lecture. And that refers to the top of the funnel, what you could cover. Then you go through and you just start slashing, cross out anything that you could cover, and leave the things that you should cover. Then go through and cut out anything that maybe you should cover, but you don't have to cover. And whatever you're left with should inspire your 1 to 3 learning objectives. So don't be afraid to cut ruthlessly. This is how you get to the up-to-date lecture. You know what I'm talking about? Where it's like the person's literally reading up-to-date. They didn't go through and they didn't ruthlessly cut the things that didn't have to be covered. And this brings me to the ideal lecture time. There hasn't been the most robust literature on this topic, but of the literature that has come out in the past, century, a lot of it has come to the conclusion that the ideal length of a lecture should be around 20 to 25 minutes. Now this is tough because we don't always get to pick the amount of time we're given. Maybe you're invited for a grand rounds and they want you to speak for an hour. If that's the case, then what you can do is break up your lecture time, so lecture no more than 25 minutes at a time, and build in some sort of active learning to break up the chunks. And you'll hear more about techniques to do that down the line. So how will you get your learners to where you want them to get? And this is where educational methods come into play. And not to beat a dead horse, but your educational methods should incorporate active learning. And again, you're going to hear more about that as we go. But it's also important here to think about cognitive load as you design your lectures. And we have the benefit of having a local cognitive load expert here, Jason, who is brilliant when it comes to this, and several other colleagues in this room who have written, yeah, he literally made this graph, who have written about cognitive load. And I love cognitive load theory because it applies to like so many things in life. And I find it applies so much to what we do on shift too. Like, I feel like we all have so much cognitive load when we're working in the emergency department, but it's also super applicable to what you need to think about when you're creating a lecture. So what is cognitive load theory? In the simplest terms, cognitive load theory helps us understand how we take sensory information from the world, so visual and auditory information, how it comes into our working memory, which is limited. We can only we know, as a much larger storage capacity. It also refers to then how we retrieve that information from schema, which refers to the way that it's kind of organized to make sense in our brain, and bring it back into working memory when we need to use it. And so cognitive load refers to the information processing activity that is required to manage working memory. And as teachers, we really need to manage that, and we need to optimize it so that we can maximize what our learners can actually commit to memory from our teaching sessions. So how do we do this? Well, it helps to think about the different types of cognitive load and what we're trying to do with each type. So intrinsic load basically refers to how challenging the material is. Is it super simple or is it very complex? And we only have so much control over that. At the same time, we do have some control, so we can choose to simplify content as much as possible in order to manage intrinsic load. If there's a simpler way to say it, a simpler way to present it, that's usually going to help. Second, we can maximize germane load. So germane load is a little bit harder to understand. Germane load refers to how we link new information with old information. And this really refers to how our brain organizes content into these schema, these ways that we can perceive information rationally with what we already know. And then lastly, we can minimize extraneous load. So extraneous load is what we have the most control over. That includes how we choose to present the information. It includes like the amount of text or pictures that you have on the slide. It can also include things like environmental factors, so how noisy the room is or what else is going on around you. And this is the one you want to minimize because usually it's all kind of harmful and distracting, unnecessary information that's taken up limited space. So this beautiful table, written by Drs. Wagner and Manthey and Wolf and Santen and Jordan and Cico, provides us with a table that tells you practical strategies that you can do for each of the different types of cognitive load when you're designing lectures. So for instance, for extraneous load, you can minimize environmental distractions. You can rehearse the session in advance to make it run smoothly so that it's not distracting when you appear to have lost your place or have a hiccup. For intrinsic load, you can take content that you're presenting and activate prior learner knowledge before you introduce new content. You can limit the amount of material to be covered. You can tailor the content to flow from simple to complex. And then for germane load, you can utilize schema to present information. So kind of that like 4-question framework that I showed you for applying to lecture design, that would be an example of me giving you new information and providing you with a way to organize it in your brain. So now we get to the end of this process. How do you know if your learners got there? This is that kind of evaluation and feedback piece. So how are you guys all doing this? When you give a lecture, how are you assessing whether or not it's landing, whether or not your learners are getting the content?
We have a Manthey survey. It's not very good, and I think people just click behind it.
That's probably the most common way people are getting feedback. What else? So there, yeah.
I recently took like a really short exam on it. Now you get kind of mark their right for being a bug and you just
Yeah, asking them to discuss the topic you just taught and kind of see how well they internalized it. What else? Yes. Yeah. Is everybody kind of doing other things? Are they citing charts? You know, or they actually seem like they're paying attention? You can glean a lot just from, you know, reading the written for sure. But this framework, this is another just concept I want to introduce to you all. This is called practice levels. And this just gives a way of thinking about outcomes from any sort of intervention. You can apply it to education. It's been applied to other things. But you can see, again, it's a pyramid. Shocker. On the bottom, you have kind of the lower level type of outcomes like reaction. So this is assessing, did your learners actually enjoy the activity? Were they satisfied with it? Did they like it? Next is learning. Did you actually transfer knowledge, skills, or attitudes? Was there a change based on the intervention or the content you delivered? As you get higher on the pyramid to things like impact, where you actually assess if there was a behavior change or results, if there was an outcomes change, those are higher yield in terms of suggesting the impact of your intervention, but they tend to be less feasible to get, especially if you're just doing this for one lecture. So reaction and learning tend to be the most common ones people look at. And reaction often comes from a survey, right? Whether it's the MedHub survey. One thing I think is a good technique is actually put a QR code at the end of your lecture so that your learners can then learning, you really need some sort of pre and post. So if you do a Kahoot at the beginning and the end, and then you can assess if the percentage correct changed. You can also present a case at the beginning of the lecture and then at the end of the lecture and see if the answers of how a learner would go about that case change. So those are some ways that I've seen people incorporate this into their content. So here it is, 4 steps to didactic design that I want you to take away the next time you have to do this. Where are my learners? This is where doing that needs assessment, doing your lit search, looking at the phone med stuff, talking to your learners comes in. Where do you want to get your learners? Use the spray map, start broad, funnel down, 2 to 3 learning objectives, write them using best practices. How will you get them there? Try to lecture no longer than 20 to 25 minutes at a time, incorporate active learning, optimize cognitive load. And how will you know if they got it? Consider outcomes and how to measure them in advance. And with that, any questions before we move on to the next section?
Make a comment about the grand round. You brought up the 20, 25-minute lecture, so we converted all 25-minute lectures a while back. And the grand round, nobody wants to be invited to grand rounds that only for an hour either. So what we ask them to do is spend the first 25 minutes of their lecture talking about the science behind whatever it is they're there to discuss. Then the last 25 minutes we talk about the clinical application of the science. So there's a break in the middle. And so you get that cognitive rest in the space and the content. And they're more open to that.
Yeah.
You only get 25 minutes.
Yeah, that's great. So we've actually stole this from memory, but we now invite each grand round speaker to speak the whole time that they're giving like a pre-made lecture or to sponsor either underrepresented or junior faculty members to use the second half of the time. That way it's 2 30-minute lectures instead of an hour, which has worked out really well for us.
Get by into that. We're doing the same thing, but if you're an hour and 30 minutes.
Yeah. All right, well, since we are running tight on time, I will hand it over to Ben, who's going to talk about using technology for active learning.
Right. Wish me luck on this. As you know, using technology for anything is always a dicey proposition with these things. So we're gonna see if we can make this all work here. Apparently the projector is going to reboot. All right, so I'm Ben Schnapp. I'm indeed going to talk to you guys today about interacting with your audience and how does that work during a didactic session if you're doing a lecture. So true to form, we do indeed have some learning objectives for you here. Hopefully going to talk about some of the value of audience engagement, talk about some of the different options that you might have for engaging your lecture audience, and then do some compare and contrast about what the advantages and disadvantages of some of these tools are. So you might be familiar with this. People have often seen this before, suggesting that retention rates from lecture are very low, perhaps as low as 5%. Hopefully, if you've seen this graphic before, you've also heard that it's dead wrong. This is not really based on any solid evidence at all, and it's one of those pervasive education myths that just kind of won't die. So if this is a reserving spot in your brain somewhere, you can get rid of it now, make room for some other stuff instead. If you think about this, this really makes sense, right? Depending on the lecture, the speaker, the topic, your level of tiredness, what else is going on in the room, if it's noisy or distracting, you might learn a ton from a lecture, or you might not learn anything at all. So the variation is a lot. It's not just a blanket 5%. So what do we have solid evidence for then? Well, we do have great evidence that retrieval practice really works. Making people answer questions and consider their prior knowledge, engage them with their material, creates better retention than just letting people passively absorb from sort of one-way information transfer from a didactic lecture. This makes intuitive sense too, right? We've all zoned out for a while in lecture or spent some time closing some charts that needed to be closed, and then zoned back in to find out
that we missed something really important. You've missed the key portion of the lecture. You've missed the main learning point. You're like, well, now I'm really going to zone out because I've kind of missed it now. This just doesn't really happen, or happens much more rarely if you're being asked to answer questions and engage your brain periodically. We also know that active learning works, right? This is what Mary was talking about in the last section. If you're not quizzing them on their knowledge, engaging them in discussion, problem solving, analysis, role play, case studies, anything like that is going to help them understand and recall the material that you're trying to teach far better than just lecturing at them alone. There's almost no lecture that you can give that wouldn't benefit from engaging your learners more with their existing knowledge and perspectives to ensure you're maximizing the educational yield of your time. The problem is when you're assigned a didactic lecture, if you're given 30 minutes or even an hour in conference, there's not a lot of obvious ways to do that, right? So you guys kind of know what the options are. You could call on people who raise their hand, but that really only confirms that the people that you already knew were paying attention are paying attention. You know that those people are getting what you want them to get from the lecture. You could call on people at random, people without their hands raised, but now you're kind of hearkening back to the bad old days of medicine where learners are in fear of getting pimped at any time. It really doesn't do much for that culture of safety, a learning mindset, learning environment that's conducive to learning where it's okay to be wrong. It sort of sets up an adversarial environment there. So there's got to be a better way, right? So that's what we're going to talk about here, is audience response technology. So this is the old standby here. Raise your hand if you've used Poll Everywhere before. Yeah, everybody has seen Poll Everywhere. So we're going to get to the interactive part of this right now. Here comes the technology. Let's see how we go. So this is going to be dependent on the ability to get the second screen working again. Where did that projector go? Yeah. It's not turning the projector on at all now, though. Which is interesting because it was on before. Oh, okay. It does. Oh, here we go. Here we go. We're back. No, I think this is good. That'll work. Yep. Because I got to get this over here. All right, so we're going to get this going here. So you guys know how this works. I want everybody to sign in on your phones here. You can text the little code up there. What do you think of Poll Everywhere? So rather than ask everybody directly, I want you to use this and log into this here. And tell me what you think of Poll Everywhere. Your responses will kind of pop up on the screen here. Oops. We'll go back here. Either way will work. So this is the problem with Poll Everywhere, right? We're experiencing it right now. This is why I don't love Poll Everywhere. Because you're assigned, 20 minutes, 30 minutes to give your lecture, and what do you end up spending a ton of your time doing? Waiting for people to use the cumbersome login process, try and figure out what your incredibly long secret code is, and then actually waiting for people to think about what their response is and actually send you something and type this in, right? We're probably going on at least a minute we've just, forget about the tech problems, but with just a poll everywhere thing in the first place. Have people found uses for poll everywhere that they really like? What's been effective for poll everywhere? Or do people just hate this?
I like the fact that the poll everywhere is embedded in the presentation with a lot of the other software that fill out the page and back.
Yeah. Yeah, so that's a really good point, right? If it works, and sometimes the embedding of the polls can backfire. It doesn't always work if you're, sending it somewhere else or putting it on a new computer. But yeah, if it can be a really nice, integrated experience with a slide deck that you already have. So you can take a lecture that already is pretty good, and you can add audience response to kind of take it to the next level. Has anybody had any success with doing this, or it's not working? Let me see. It says that it's activated on here, but we'll try activating it again. Yes, exactly. So despite the fact that this was already activated, it wanted to be reactivated for whatever reason. So it's not perfect. I think that's a really good way to think about it. It can do some cool stuff, though. This word cloud is kind of fun. I don't know how good it is for learning, but it at least gives you a sense of where people's heads are at. And I have a pretty good sense of where the audience opinion of poll everywhere is right now. But if you want to look at the upside, we've got maybe a cooler thing. So if you're trying to teach a radiology lesson, something like that, you can actually have people play along in real time. So they should be able to see this on their phone, and you can say, oh, well, where do you actually think the problem is? You don't have to point it out for them. You can have them kind of do the thinking themselves and take a look at your images and actually read them in real time. So maybe a way to do some pretty cool image-based stuff. And you can think of, there's probably a lot of different examples where this might be useful for you. All right, so we're going back to slides. Yes, you should be able to. Yeah, many of them you have that option now because, yeah, you don't want necessarily, and we'll see some examples of this, but you don't want the prior folks' responses to influence what the subsequent responses look like. So how about these? Anybody ever heard of Mentimeter or quizzes? Yeah, a few less people, but these are what I consider the PowerPoint replacements. So this gets to what Jason's talking about here, which is this idea that of embedding in your current presentation or actually replacing PowerPoint. So both of these want you to replace your existing PowerPoint or build your presentation in their software on their website and then present directly from the site. It can be nice for seamless integration, tends to be available wherever you go, but if you've already got a slide deck ready to go, it might not be the best thing, and it kind of limits you in terms of the interoperability. So if you, for example, get tired of Mentimeter or they raise their prices to some sky-high level and really want you to pay for their services, you're kind of stuck with them. You're not really going anywhere else because you've built your entire presentation in their software. So we'll take a quick peek at one of these. Boy, now the hardest problem is finding the mouse. There we go. No. Where am I here? So this is a presentation that's built in Mentimeter. It's kind of like PowerPoint. It's a lot like PowerPoint. But it can do some kind of cool stuff here. So you can try this out for yourself. There's a new website and another long code there. So you can place different items on a graph here. So you can rank them by interest and educational value to the program. Say, yeah, you know, I'd be pretty interested in a new talks curriculum, but I don't know, we already have pretty good talks education, so that's maybe of lower educational value to the program versus I'm not going to be interested at all in a joint cardiology conference, but you know, the program might need such a thing. So you can place things on 2 dimensions. Kind of interesting. Yeah, there we go. People are putting some things on the graph, and it'll change those in real time. Kind of cool. A different sort of audience response system than I think can be seen in some of the others that are out there. We've also got real-time graphs, so you can use this for something like getting resident opinions on things in real time. You could use this to assess learning, but nice, easy, straightforward, colorful, but got to do kind of the whole presentation within the Mentimeter software itself. So it's a good question. Most of them have some kind of trial level that you can usually get by with for you know, limited purposes, limited number of users, but it's worth checking on these because different ones have different limitations that may or may not be limiting to what you have in mind. So, for example, let me see what I've got them here for Mentimeter. So the free version of Mentimeter is this one's actually pretty good. So this one is unlimited audience and unlimited presentations, but you can only put 2 question slides and 5 quiz slides in there. So they want you to build a whole presentation, but if you really want to have a lot of audience response, that's how they're going to limit you. And quizzes is a little bit different. They limit you to 100 learners. So you can only use a certain number of you know, folks. If you're trying to use a big lecture to a bigger audience, that's when they want you to pay. Yep, totally works as well. So this is quizzes here. Going to give you guys a quiz on the cell membranes. So you can hop into the quiz here. Here, actually, maybe easier to join via QR code. All right, we got people in. All right, I'm going to start us up here. So this has a lot of similarities to Kahoot. Yeah, but I want it to actually play. Are you guys seeing it? Okay, good. Yeah, I took this one last night. It was a little harder than I imagined. So this is nice. You know, we'll talk about Kahoot in a second, but I feel like this is a little less aggressively paced than Kahoot. Kahoot really gives you a lot of rewards and really wants to emphasize fast responding, which I feel like is not necessarily everybody's style, maybe not necessarily the thing that you want to incentivize. So this is a little friendlier than that. It's lighthearted. There are little, you know, memes that you can add in there, so you know you can feel connected to your younger generation learners. it's a nice thing for what it is, but this is a pretty quiz-focused thing, as the name kind of implies. But it also tends to be fairly, there's not a big group visual component, so you can see everybody is kind of staring at their phone right now. This might be good for an after didactic activity to do some, assessment on something that you just taught them, because there isn't really a big group component. There's not something that everybody's looking at. This is really, can be thought of potentially as an after the fact type thing, or self-paced learning. All right, we can put that one aside, and we'll go now to Slido. Anyone ever heard of this one? Yeah, so this is kind of the opposite end of the spectrum. Nothing really new here. It's the usual multiple choice, word cloud, free response type audience response system. Unlike the previous two, it's not necessarily trying to take over your presentations. It really wants to integrate with whatever you're using. So it's got tons of plugins designed to work well with PowerPoint, with even Microsoft Teams. You can integrate Slido audience response in there. You do have to download some software, so this gets to kind of the downsides of some of these integrated models. If you're presenting on, for example, a corporate or university laptop that might not have the ability to install extra software, it can be really frustrating to get up there, have your beautiful audience response system all ready to go, and oh no, it doesn't work because the software isn't installed or the internet connection isn't good. So this is something to test ahead of time. This is a downside of these particular systems that you can be aware of. But we'll pull up a Slido example here so you can see that. So this is a good example here of what we were talking about before. Let's say you're going to give a lecture on, infectious diseases for the returning traveler. Here's your real-time needs assessment right now. Are people experts in this topic? Have they heard about this before? Have they just gotten a lecture on this? Or are they pretty unfamiliar? You've got to start at the very basic level. This is nice. You guys can see the QR code is probably a faster and easier way than trying to type in some fiddly little URL. So this can be nice for that reason alone. But just another potential alternative, and some pros and cons with this one as well. Did everyone get in? Is this... All right, and then I think I have, this one I have hidden the responses. So now you go down here. Good, so then you can say, oh, nobody else's answers influenced the responses here, and you get to see, okay, we can start at a fairly basic level here, but we're not starting totally from ground zero for your lecture. All right, I bet you were all wondering what those squares were on your table, the weird squares. Has anybody heard of this? Cool, what do you know about this? Describe what this is. Absolutely. So this is kind of weird, right? There's nothing to log into. There's no, system, but it's kind of nice. It's got some unique pros to it for an audience response. So one of the frustrating things we already talked about with audience response is you got to sit around and wait for everybody to log in, and then you're like, oh, should I wait another 15 seconds to let's get one or two more responses. Everybody else is sitting there bored, like you've really lost the audience engagement that you're supposed to be trying to create. This is awesome because it's instant and it leverages peer pressure in a positive way. Nobody gets to see what anybody else is giving for answers because they're just holding up a weird shape. But everybody's pressured to participate. If you're not holding up your square, I can be like, it's time for you to hold up your square now. So we can give this a shot too, and we'll see if this works. Come on. Yeah, right? All right, so here we go. Everybody hold up whatever response they feel like is most appropriate here. I'll get out my handy dandy app. And you do have to do a little walking around the room here to try and get everybody in. But you can see, as people get scanned in, their responses come up. You can also have this update in real time. But there's your list of the responses there. So I've used this in the past successfully with rapid boards review questions. It's actually really nice for that because it's like, let's do this, let's keep this rapid fire, we're not waiting for people to respond, flash up your first answer, and let's keep this thing moving. So if you're looking for a rapid type thing where you want to get as many people thinking about it and engaged as possible, this can be a nice way to do that. How about Kahoot? Anybody seen Kahoot? What do people think about this? Do people like Kahoot? Do they not like Kahoot? What's good about it? What do you like about it? Why do you use it a lot? It's definitely a whole thing. It's definitely the Kahoot mood is. Right, so there's some medical education theory that suggests that turning things into a game is good for engagement, it's good for learning and retention. So yeah, there's kind of something to that idea, right? Do people get into it or do they not get into it? Yeah, yeah, they sometimes a little too much they get into it. But yes, absolutely, people are really very much into it. What about other people's experiences? What do other people use Kahoot for? Yeah.
Low stakes, like everyone gets into it, like you can even be anonymous, you can make up like names, like
Yes.
everyone can participate, they don't care if they get wrong or right.
Which cuts both ways, though, right? Sometimes we have seen things get a little too far in the silly direction with, the learning becomes secondary to who can put in the silliest name, and that thing can sometimes derail the positive energy. We've used them for real-time needs assessment. So before a lecture, like let's do a couple of Kahoot questions to see where folks are at with this. Again, we talked about speed is highly incentivized here. Maybe this is unfair a little bit to slower processors who might also have the right answers but aren't necessarily going to rise up the board. Again, this is low stakes, so it probably doesn't matter. Maybe competitiveness might detract a little bit from the focus on learning. And the free version of Kahoot is not too useful. So you really do have to have a subscription here. Otherwise, you're limited to 10 players, which is not really enough for most people's didactic conference. So pluses and minuses of that too. Yep. Yep, it doesn't because it takes a big part of the screen available for the buttons, you're right. Some of that larger content can get lost. So that's a really good point. I hadn't seen that switching back and forth thing, but yeah, it totally works. All right, we won't do a demo of that because I think people have seen it. Have people seen this? Do people know about Jamboard? So this is kind of cool. This is not your typical audience response. We're kind of leaving and going into a different domain here. This is something where kind of everybody can play and contribute. Google Jamboard is probably the most free form of these. You could use this for activities with kind of less boundaries where you need the input of the group. You might want to get a sense of what people know and how their knowledge is constructed already. But the outcome isn't necessarily certain or needs to be kind of built in real time. You really need to know everybody who is participating. This is probably not something that you could do if you were doing, a lecture to a large audience where you don't necessarily know or trust everybody because you can get bad behaviors and there's not really necessarily a great way to moderate this. Probably better thing for small groups than to get like 100 people going on something like this. And everybody needs a Google account. So this is what this looks like here. So we use this to do some brainstorming about assessments and what people have seen and how people do assessments. We were using sticky notes for this and allowing people to create their own sticky notes, move them around, and then on the next Jamboard, place them in different categories where we thought that, that they made sense. This is just one way to do collaboration with this. You can write on here, you can draw shapes and whatever you want, but this can be a nice way to sort of work collaboratively with folks in real time. Again, you need laptops. People need to be able to actually access this and to be able to contribute. So going to take a little bit of advanced preparation and probably only for certain audiences, but can be a really powerful tool. And obviously with Google, it's all free. Come on, come back up. On a similar note, this is another mind mapping tool. This is Miro, and this is a great one for ideas that connect to each other. So really good for mind maps, concept maps, flow charts, org charts, meeting agenda, storyboards. So if you're trying to get your residents engaged in the structure of something, structuring knowledge in real time perhaps, this is something that Miro does really nicely. It also incorporates some theoretical frameworks from the business literature that can be a helpful way of reconceptualizing some of your ideas and pushing towards a fresh approach. So might be helpful if you're thinking about things in that context or want to bring a fresh framework to some of your work. So show you briefly what that might look like. We've got Miro right here. So this is some of the mind maps. It does these little flow charts very well. You can add these or subtract them if you don't like them. You can write stuff in there. It does graphics. You can draw stickies, shapes, arrows, all of that kind of thing. So if you want to sort of help construct a structure of knowledge in real time, this can be a really cool tool for that. And we've got the last one of these, which is Padlet. I call this kind of the modern collage maker. It's really a tool that's designed for media. It's really not so hot for text, and this is fun. You can really put a whole bunch of things on here if you want to start adding things to your board. Even though GIFs are now for old people, this feels really fun to get involved with. So I'll show you the sorts of things that I was putting on a board as of last night when I was playing around with this. I was putting together some ideas for a new resident room. So you've got some animated stuff here, pictures that you pull from the internet. It'll pull music from Spotify. And it even hooks up with ChatGPT to generate images, so that one over there on the left, Tasty Snacks, is an AI-generated image of whatever you want. So if you're looking to create something really visual that people can kind of share and collaborate on together, again, could see some really interesting educational possibilities for something like this if you wanted to sort of collaborate on a didactic experience. This is called Padlet. And then finally, we're going to finish with one that I think people are familiar with. How many people knew that Zoom is an audience response tool? Have people seen this capability used before? It's actually pretty cool. You know, you would think after the pandemic that we all would have known every feature that Zoom has ever done. But what you can do with it, let me fire it up here. So when you go down here to your share screen option, you have the ability to share your standard PowerPoint. You also have this ability to share a whiteboard. I'll show you how to do this with sort of both methods, but just brings you to a blank board and the ability to draw. You can make stamps. You can annotate. So here, let me see. You got to bring this over. But there's the ability to add text. Everybody on the Zoom call can contribute, so they can all write whatever they want, and it's seen by everybody. Spotlight certain stuff. Working, but there are little stamps that, yeah, there's the stamps. So this can be really fun. You can take a regular PowerPoint that you're presenting over Zoom that's like kind of not too engaging, you know, everybody's turning into the little black squares and you're like, I don't think anybody's paying attention to this lecture. And if you turn this ability on or ask people to start putting little stamps on or start responding to your lecture in the real time, it can be a really nice way besides the chat to actually engage your audience over Zoom. So I know that we're mostly leaning away from the Zoom era of lecture, but I know it's not going away completely, so this can be a nice tool to have in your toolbox. And all of this works just as well sharing over the top of PowerPoint slides as well. So you want to know, I've just shared 10 of these different audience response pieces of software with you. Which one of them is the best? Which one should you use? What's the clear gold medal winner that you should choose for your next lecture? And I would tell you, unfortunately, I don't think it's that simple. As was hopefully made clear over the course of this talk, all of these are slightly different, depending on your audience, the goals for your didactic, the setting, the time, your audience, among many, many other factors. Different tools may be more or less appropriate for your didactic session. It's not really a matter of picking a winner. It's about finding the right tool for the job for your specific talk. You may end up with favorites from this list that you are going to come back to again and again, and that's totally fine. Just like you might have different preferred teaching styles that you prefer and come back to time and time again. But don't try and fit a square peg into a round hole. You should be facile enough to be able to switch and say, you know what, that's not really going to work at this point. I'm going to try this other audience response tool instead, and that's going to be a better match for what I'm trying to do today. It's also worth noting that you should come back and check out these time and time again. These tools change over time. More features are added. As we were talking about before, the ability to hide and show responses, new types of polls, that kind of thing. So there may be features or even entirely new audience response softwares that we didn't even discuss today that's perfect for your next award-winning talk. So keep an ear to the ground to what's available. And remember, at the end of the day, the end goal here is active learning, audience engagement, and avoiding scenes that look like this. Don't forget lecture fundamentals. It's really all about telling a compelling story using visuals and not text that enhance the message that you're communicating. In addition to thinking about the right tool for the job, it's probably beneficial to think about whether audience response is the right thing to do for your lecture at all. It might be that your lecture is better as a chalk talk, a small group session, question and answer, or maybe a completely different format that doesn't incorporate high technology in any way. So hopefully we hit some of these learning objectives today. For the next steps, the future is really yours. Go out there and teach your learners really great stuff using this technology. Thanks.
And I just wanted to say one thing. I've thought about this so much, especially with like the switching from Zoom and then in-person and back visiting and the hybrid model. And I feel like just something I've kind of come to a conclusion of is it really depends on my audience. If it's like a safe audience, people I know or I feel like I can experiment, I'm more likely to use these tools. If it's a higher stakes audience, a lot of people I don't know, I just feel like the opportunity for tech failure is so high that I tend to stick to like go by methods of just asking questions and using the Zoom chat. I also really like this in using Zoom because then you don't have to deal with like switching back and forth. And the polling feature is great in Zoom. Like we did a session with medical students about professionalism around sign out, and I had to ask them a lot of questions like, here's a hypothetical scenario. A patient needs an altitude sign out. Are you staying or are you going to sign that out? And normally I think they feel shy to say like one answer versus another, but when it's an anonymous poll and you can display the results, you get much more candid responses, and it leads to much better discussion because then people aren't shy to say, well, actually, I was one of the people who responded to this, and like this is why.
100%, which really, it goes to show that, it really is about the right tool for the job, and it doesn't have to be the fanciest, highest tech thing with music and scores and, all that stuff. Like, sometimes you just need the ability to do a quick poll and to do something that will kind of pull people out of their black Zoom squares. So, yeah, I mean, I think that's a perfect illustration of, use what tool kind of matches really nicely for what you're trying to accomplish. Do other people have questions about any of this? I know people have seen some of this before. People had frustrations with this where it didn't work. People have wondering whether I could do this.
What about the old days of security? Code. I mean, we're used to that.
Like a quiz on like the.
Like a quiz, a paper quiz. I don't know.
Yeah,
I feel like we make things, especially if it's a short 5-question quiz, it's more time grading.
Yeah, I mean, I think it sort of depends. It's certainly another tool to have in your toolbox. I think that, it's potentially a little bit of a limited one in my mind. I think it's got some of the right principles, right, of engaging people with the knowledge, seeing what they know. But, right, with the pre and post, like how much are you really going to be able to cover? It's going to be some additional time for you and for them, and what are you really getting out of it? So, there might be some scenarios where that totally makes sense, and you do want to make sure that, like, boy, I really need to make sure that absolutely everybody knows, like, this new protocol that we're doing for stroke in the emergency department, and I need everybody to answer those questions correctly because I want to follow up individually with anybody who doesn't get it. Yeah, that might be a great situation for a pencil and paper kind of assessment that way. So yeah, totally possible. Perfectly fine to think of lower technology solutions for this. Interesting. I've never seen those, but that sounds fun.
So, speaking of old tech, that segues perfectly into what I'm going to talk about. So I think Ben and I both have the goal that you're going to step out of your comfort zone and you're going to try something different next time you have your talk. So just out of curiosity, tell me, who do you normally give talks to? And I'm thinking more of the size of the group that
So these techniques, the things Ben talked about, are a lot of work, right? You have to prepare for them. Are they going to work for a group of people? Maybe not, depends how often you're going to do them. So I want to ask you guys, what are some of the things that you've done that engage your learners so that we can learn from each other? So tell us what you use, and then also maybe the size of the group that you're using it with. that you can use that are really fast to engage your learners at the end of this as a follow-up email. So look for that, and it's been great talking.
I noticed my, I kind of emailed that my QR code with the SAEM learning objectives is deactivated. Sorry, but if you just Google SAEM learning objectives, you'll easily. Sorry. I have kind of
Are there any questions? What did they set up?
All right, well, thank you. So we're going to go over slide design, and really, as you kind of introed for me, storytelling and integrating storytelling into your presentations. And what I would love to do is to have people from the audience, if you have an example of a difficult concept that you're trying to translate visually, I'd love to actually take something that one of you is working on and we could do it together and try to solve this problem together. The reason we like to use visual presentations is because the way that our brain incorporates the written word versus visual imagery is much more simplified with a visual image. So if I say lion, you have a little part in your brain that just stores what the image of a lion means to you. If I write out the word lion, you actually have to reassemble the individual shapes that make up the letters, that make up the words, that make up the sentences, and you pull those from disparate areas of your brain to put that together to make the word lion to then create the image of a lion. So it's a lot more cognitive work for you to do if you're trying to read a slide. And if I just have words on a slide that you can read about 7 times faster than I can talk. And since you have the cognitive overhead to read that fast, you preferentially read instead of watch and listen to me. And so while you're doing that, you can't listen to me. You can't read and listen at the same time. So you will preferentially take the fast route, and then you'll come back to me after you're done reading whatever it is I'm talking about, and then you will pick up wherever I am, and you'll have lost everything I led with. So those are a couple of reasons why we like to use visual imagery. And if anybody has a thought on a concept, we can start with that. Does anybody have an image or an idea of what they'd like to visually demonstrate in a presentation? Ambiguity. Ambiguity. Jeez, I mean. What are you trying to teach with about ambiguity? What? What? That's a challenge. Okay, that's an interesting one. Okay. So I'll use this as maybe an example of that. And so this is actually the slide that Mary showed. But I created it, so I actually had the breakdown of that slide. And so Mary showed a graphic that is actually pretty busy. And there's a lot of content on there because it was meant to be in a journal with explanations, and then you could refer back and forth to it. So if we want to think molecularly about this a little bit, so this is how we take in, this is how we learn. We use our sensory inputs, and those sensory inputs gather new information, and that new information is hopefully consolidated in a way that stays within our working memory as we process it. And over time and repetition, we incorporate those schema into our long-term memory, and then we recall that when we need it back into our working memory. So just by using a few simple tricks of motion and graphics, you can help deliver a message that's more meaningful for your audience. So I think that, and I can, this, to me, this kind of looks like a cell a little bit, you know, so that's why I thought of that. What do you think about that? Yeah, so let's go through that a little bit, and that's exactly what I'd like to do. And this is through something called Magic Move, and on Keynote, I'm a Keynote person, and if you're looking at it on PowerPoint, it's called Morph. Now, I'll warn you about PowerPoint in that only the latest edition or the last couple of editions of PowerPoint actually have Morph on them. So I've had residents I've helped coach for lectures who've used Morph, and if they're not using the most updated software at like this conference, or it was Cord, was the last conference where this happened, then Morphs don't work. So you have to make sure that they're using the latest software if you're going to use PowerPoint. If you're a Keynote person, then you have to make sure that they're going to allow you to use your own computer for Keynote. So the way Magic Move works is it takes an image and makes whatever change that you put into the image occur. That sounds complicated, but I'll show you an example of where I like to use it. So this is a flow chart of I don't know what I want to do with my life in medicine, and walks your way through. When you look at this in and of itself, it's really busy. So what I like to do with a busy diagram like this is just incorporate Magic Move, and I'll start with a simple structure. All I'm doing between one slide and the next is changing the size. So this is my second slide. And then on this, I'll add an animation, and I'll add a Magic Move. So all it's doing is taking the difference between the first picture and the second picture and making it happen. So this is one way you can do it. So when I show a busy graphic like this, instead of just saying this is a really busy slide, I will guide my learner through it like this. And all we're doing is we're just now taking this and copying the slide and moving our way through. And I copy the slide and paste it back, and we move a little further through. So as we go through now, we can say, instead of saying, I have this really busy slide that you probably can't read, we can actually work our way through it. I like nothing. Oh, I forgot to put in my Magic Moves. So again, I can just take this, select them all, and add an effect Magic Move. How are my grades? They're okay. Are you a huge nerd? Not much. What do you think of kids? Love them. That's a lie. I'm going to go into pediatrics, okay? And so you're working your way through. And this does two things. One is it makes this legible for your audience. See, now I'm distracting you by giving you shit to read, right? So it allows my audience to actually be able to read this. But the other thing it does is it controls your pacing. It keeps you from getting ahead of me. And if I wanted to spend a little more time, you could actually create a frame around this, and then I could actually focus on very specific parts of the slide. So that's another simple way to use Magic Move. And pacing your audience can be really important, especially when you have a lot on a slide. And so I'll give you another example of a way I like to use Magic Move. And we're going to flex Magic Move a lot, or again, it's called Morph on PowerPoint. So let's just say I'm trying to demonstrate a patient population and how something can impact what happens with them based on, let's just say, CT. So this is actually, I don't remember the data anymore, but this is based on a study where they were determining whether patients could go home or stay. And so what we're going to do on here is we're going to put in a hospital. And I want to do this in real time because I just want to show it's actually fairly simple. And then we're going to put in a home. That home looks nice. We'll take that one. All right, and now I have this patient population. Let's call it 1,000 patients. Each patient represents 10 people. Each stick figure here represents 10 people. So, or whatever it is. So this is going to be, you think backwards on this, and I always save my slides. So you notice I have one slide that's a duplicate now. I always save a duplicate because I'm going to do a lot of stuff to these slides, and I don't want to lose my original material by morphing it too much. So what I want to say is, you got examined by a doctor, and after examining the patients, the doctor determined whether or not they needed to come to the hospital based on their abdominal exam for abdominal pain without a CT scan. So let's just say that after examining them, 60% of the patients, I'm just guessing on these numbers, needed to go into the hospital, okay? So I'm taking these patients and I'm putting them into the hospital. I won't go through everything to hide these guys, but normally what I would do is I would shrink them down and have them actually have them so you can't see them anymore. All right, so these guys are going that way and the rest are going home, okay? So I put in a magic move here. And what this does is it gives your audience a visual representation of what's happening. So it's not just a number, it's not just a percentile, it's actually like, oh, I see, like the vast majority of patients need to stay in the hospital with abdominal pain if I can't do a CT scan. And then what you can then demonstrate with the CT scan is how many patients, how many patients would in turn not need to be admitted to the hospital. So now it's like, we'll just say it's a nice flip and all these guys get to stay in the hospital and then all these guys get to go home. And it demonstrates then to your audience the power of being able to do a CT scan and how meaningful it is to your patients that they can go home instead of staying in the hospital. All right, so then with that, we would just add one more magic move. So then the whole story becomes you have all these patients. If I can't do a CT scan, 75% of them end up coming to the hospital. But if I can do a CT scan, 75% of them end up going home. And I don't know why I missed a morph there somehow, but something got mixed up at the end there. But you get the point, I think, right? So it gives them that visual representation of what they can do for their patients. Any thoughts or questions or other ways that you want to try to apply this real quick, or any other concepts? So I'm going to show you one other thing I like to do, and that's something, these are visual cues, and this is, I can't remember who brought up the number of learning objectives you should have. 3 to 5 is kind of the general concept, but who do we teach? We don't generally teach just medical students. We very often are teaching from med students to professors. And so how do you create learning objectives to keep that whole audience engaged when they're at all different learner levels? So one of the things that I created with one of my residents was, he was from Wisconsin, so he wanted the cheese model. So we used a visual cue for the audience, and anytime there was a soft cheese in the picture, so it was brie, he showed them all the key. So brie was for the junior learners, and cheddar was for the mid learners, and then he had a hard cheese of some kind, I can't remember what, for the seniors. So as you're going through a slide and you see your chunk of cheese show up, that's your visual cue, like, oh, this is a bit for me. So if I let the rest wash over me, that's fine, but this is the 1 or 3 bits I'm supposed to take home today. So just another little visual cue, but you have to let your audience know ahead of time, I'm planting this visual cue in here for you, so pay attention when that comes up. You could do an audio cue, I suppose, too, potentially, but I think the visual cue is a little more lasting. And then to continue with the visual theme here, I'm going to create what I call a visual list. And this is, again, using Magic Move. I don't want to make it sound like the only thing I know how to do is Magic Move, but it's such a powerful tool, Magic Move. So a visual list is when you're talking about a list of diagnoses or problems or tests or anything it might be that relate to a patient case. And we're going to do, just for the sake of making it quick, we'll just do animals. and we'll just pick a few to start with. All right, so we have our 4 farm animals here. And when you're creating a visual list using Morph or Magic Move, you need to think backwards. So you have to think, what do I want my last slide to look like? And so this is going to be my last slide. And all I'm doing is kind of working on my shaping here, my size here. All right, so here's my last slide, and for good measure, we'll put a turkey in here. And this is so the last thing we're talking about here is the turkey, all right? So that's going to be big and in the center, because that's the focus of what I'm talking about. And then we'll put in our magic move. And now what I'm going to do is copy and paste this slide. So now if you look on the left-hand side here, make that a little bigger, I'm going back a slide now. And now I haven't talked about the turkey yet. That doesn't happen. I'm talking about the rooster. And then I'm copying and pasting my slide. I'm going back. I haven't talked about the rooster. I'm talking about the hen. And again, Morph just makes the difference happen between these slides. And I'm going through this a little quickly just because I want you to, I don't want to belabor it, but I think people get the point. I'm talking about the pig, and then finally, and remember I'm doing all this backwards. So I started with my last slide and I'm working backwards. So the goat is the first thing that we're talking about in this slide. I don't know why I'm so interested in goats, but I am. All right, so then as we talk about this and we're talking to our audience, blah, 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 goats, this, that, and the other. I'm done talking about goats. Now we're going to talk about the pig. And the reason I do this visual list is you know what I'm focused on. You know what I'm focusing my attention on at the moment. But it allows you to reference back to what I talked about before and how it's related to the other concepts. So if you think about if this were the physical presentations of CHF, I'm creating a dynamic list for you around CHF. So you can now look at all this and see how they interconnect and help make some of those neural connections that will help you recall this illness script of CHF. So it's something else you can utilize is the visual list. And if you want to, depending on how you form this, what some people will do is they'll have single words or small phrases that go along. So instead of having these in this order, I might have the thing I'm talking about over here, and then over here is my list. And then I have like a single phrase that just indicates beyond just the image what I'm talking about. Some people who feel like they can't, the image itself doesn't get it across enough. So that's something else to look at. So visual lists. So the concepts with Magic Move we talked about is utilizing it to go through a large flow diagram, then utilizing it to show population numbers and their effects, and then visual lists. So those are kind of, if you want to think about the 3 things that you can keep in mind when creating visual lists, or sorry, when using imagery, those are 3 of the things. And the last thing I'm going to show you is something called live view. So this is something you can do in Keynote. PowerPoint has a version of it, but you have to jump through some hoops to make it work on PowerPoint. And this is a way to embed yourself into a presentation in real time. You could use this on Zoom so that you're part of the presentation instead of your little talkie head box. And the nice thing about it is you can preset your camera, and if you're fully immersed in the iOS system, you can actually link this to your phone, and I can use my phone as the camera. And so I have a couple of talks I give where I focus on the audience, and I mount my phone up here backwards on my laptop, and when I'm talking about the audience, I show the audience themselves as part of my talk, and it'll broadcast it in real time. So that's another thing you can do.
One cool way I've seen this used, we had somebody who talked about they had to an LMA, and they had one camera.
Yeah.
Airway mannequins, and that were talking, and like through the process, somehow they.
So yeah, it's a lot. There are multiple intubating devices that'll do just straight USB connections, and this will recognize any connection. If you look here, I just click on this camera. Oh, let's see. sorry, I gotta click on this and then go to format, live video. And up here I can choose my camera and I can add other video sources. I don't have any others connected on here, but that's how you do it. So you can use anything that's a recognizable camera source will work for this. All right, so now if I have a little time to think, does anybody have a presentation question they want to ask and we can try to make it happen? Don't be shy, go ahead.
Just a question.
Yeah.
Is it like, I've had complaints from older, like, physicians that there's too much movement on slides, so how do you find that balance when you have a diverse audience?
That's a great question. So one thing I'll say is that there's no animation should be there without a reason. So you shouldn't be doing animation just to do it. You know, like the visual list is here because I want to show what I'm emphasizing and then I want to get it out of the way and then have a list available for you. So there's a purpose behind it. So that's the first thing I would say is just make sure there's intent behind your animations. The one thing I will completely agree with you on, and that is GIFs. So I heard I'm old now because I actually don't like GIFs, but that's because I'm really old, I guess. What is a GIF made for? It's like intended to be distracting. So when a GIF is playing on the background, like the airplane, I just think when the airplane was landing, all I could do was watch the airplane land over and over and over because it's doing its job, it's distracting me. So when I do GIFs, if I do them ever, I'll let it play a couple of times and then I do a screen grab of the GIF and then I paste it over the top on the next slide. So it runs a couple cycles and then it stops so that the audience can actually pay attention to me again. Other thoughts, questions, things we want to discuss around slides? I will add that the one thing, one of the things I like people to consider is that my canvas is not this, okay? My canvas is not just the slide itself. My canvas is everything that happens around the slide. So if we're looking back at Magic Move, I can take these people, these patients, and I can have them off of my slide. And then if I do my magic move, I'm actually bringing them into the scene from off the slide. And so instead of them just popping onto the slide, they're coming from somewhere else, and it creates, I think, just a little bit more of a visual kind of movie atmosphere. And I love the concept that Mary mentioned about being the producer and the director and everything else when you're doing a presentation or doing didactics. And that's 100% how I want people to feel. Like you're a director, you're a storyteller, you're trying to create an interesting and engaging story, and you're bringing your audience along with you. And by using a few of these little tools, you can create what appears to be more of a cinematic experience for your audience. You, of course, as I can't remember who mentioned, you still have to have the basics of like being a good lecturer and being able to engage an audience. If you don't have that, none of this matters. I do a series every 2 months. We do 2 months blocks with our third years where I work on presentations with them. And I always tell them rehearsal's more important than the flash. So you have to definitely get your rehearsals in, but this is kind of the icing on the cake. Do we want to, anybody questions for me? Otherwise, we'll go to roundtable. We make a dynamic team in the end, though. All right, thanks, everyone.